Hi, how are you? Good to see you. Okay, good. Thank you.
But we're looking for more.
Okay. Good afternoon. We'd like to go ahead and start our special hearing today. This is a special joint hearing with the Assembly Health Committee and the Assembly Budget Sub 1 Committee. My name is Jim Wood. I am the chair of the Assembly Health Committee. And I want to first of all thank the city of Fresno for allowing us to use this amazingly beautiful facility. I look around, this is 3 times the size of my little city hall in my hometown, and this is a beautiful facility. So without any further ado, I'd like to go ahead and get started. We have an ambitious agenda this afternoon, and then at the end of this, at the end of all of our comments and information, we want to hear from you. The most important people here are you. So I'd like to go ahead and get started. In California, the ACA has had great success, and now we are faced with the challenge to the progress we have made for the past 7 years. Tomorrow is the anniversary of the 7th year of the signing of the ACA. When we look at the House Republican ACHA plan, we need to remember that we're talking about millions of people, real people, not a line item in the budget. Lots of statistics have been thrown about, and although they are important to comprehend, we need to understand just how this plan will affect Californians, who are the winners and who are the losers. Covered California, our state's exchange, has done amazing work educating and enrolling Californians, and indeed in 2016, 412,000 people signed up for the Affordable Care Act through our exchange. The enrollment and outreach efforts to reach vulnerable populations has led to the reduction of the uninsured population by more than half, to a historic low of 7.1%. Enrolling more than 5 million Californians in Medi-Cal and covered California health plans. California, along with many other states, has dramatically reduced the number of uninsured people, millions. Many people don't think the ACA is in a death spiral, don't think it's a disastrous law, as Republican House Speaker Paul Ryan and many others have depicted it. Instead, the people I know fear that this new House plan will eliminate benefits, stop the premium subsidies, and severely reduce Medicaid funding in California. It will also substantially raise premiums for older Americans by allowing their health plans to charge premiums up to 5 times more than the premiums for young people, and will establish an inadequate tax credit system to allow people to buy unaffordable care. In essence, you're going to pay more for less. California's Medicaid expansion now allows low-income adults without children to have coverage. Before the ACA, these folks, many hard-working folks at low-paying jobs, were left without any access to care. Although we've been told otherwise, this new plan will absolutely pull the rug out from under these most vulnerable Americans, returning to the days of rising, uncompensated care costs for our hospitals, and ultimately will leave 24 million people with fewer or no benefits at all. Let me close with some examples of winners and losers. Based on an analysis performed by Covered California and projected for 2020 under the proposed ACHA, the only people who will pay less out of pocket for their health care are people earning more than $75,000 a year. Those are the only people. A 40-year-old making $30,000 a year will pay $2,285, almost twice what they're paying now. A 27-year-old making $17,000 a year will pay $3,757, almost 6 times what they pay now. And what's most disturbing of all is if you're 60 years old and you're making $30,000 a year, you're going to be paying $11,000 a year for health coverage. That's 45% of your income. In a state like California, where we know it is already more expensive to live, this will be devastating and will without a doubt lead to many people simply not being able to afford any coverage at all. The details of the ACHA are a moving target, a daily moving target. Just Monday, there was an agreement that certain changes would be made to the bill, some to placate conservatives, such as accelerating the expiration of the ACA's taxes, and further restricting the federal Medicaid program, to placate others, including a maneuver that House leaders say would allow the Senate to beef up tax credits for older Americans. We must protect the progress that we have made in California. And remember, this is about real people, real lives, not statistics, not a budget line item. I'm going to turn this over to Dr. Arambula for his opening remarks.
Thank you all for joining us today. I am pleased to be joined by Assemblymember Jim Wood, who's the chair of the Health Committee. We are convening today's hearing right here in Fresno because Congress is poised to vote on a measure tomorrow that will dramatically change our healthcare landscape. Chairman Wood and I were compelled to address this issue here in the Valley because we have been part of the greatest successes. We have been able to enroll a tremendous amount of people in our community because of our need, and hence we will also have the most to lose if the AHCA is voted on tomorrow. Tomorrow will be the 7th anniversary of the passage of the Affordable Care Act, also known as Obamacare, for which millions of people here in California and around the country now have quality, affordable health care. Those gains in health care coverage will be radically changed if this proposal before the Republican Congress is passed. In addition, the state has billions of dollars at stake because the existing health care safety net is supported by a significant amount of federal funding. To give you an example, currently the federal government helps to support us with $67 billion in Medi-Cal alone. $15 billion of those dollars came within the most recent expansion to expand health care to nearly 5 million more Californians. The policies being considered in Congress will determine how many people have coverage in the future. Earlier this month, Assemblymember Wood and I had a hearing in Sacramento that focused on the risks that the AHCA will have on the federal funding for California. The existing healthcare net currently needs significant amounts of federal funding, and without this support, it will dramatically affect our communities. What I saw in the emergency room when I practiced medicine was the impacts this has on families and the social fabric of our very communities. I have been there when people's lives are at the very end. I have been the one to speak with their family members after their lives have passed. I know the importance that healthcare plays within our community and must implore our congressional members to be thoughtful and deliberate as they're making this important decision for our community. Now, I have decided to ask more of myself, which is why I ran for office in the first place. I wanted to help to lead a movement towards improving healthcare and finding better efficiencies within our system. But Trump Care and the associated loss of federal funding is a threat to our most important social construct, the family, in terms of jobs lost and lives lost. The New England Journal of Medicine has done an analysis, and they have found that for every 455 people that you insure, one person is alive at the end of the year. Even using a conservative figure of 5 million people that we've expanded healthcare to here in our state would equate to 11,000 people who would die in the state of California if this budget proposal that they've put forward in Congress is voted on. It is within my faith to want to help those who are less fortunate than myself, to treat others as you wish to be treated. For the sanctity of our communities, we should be standing up and defending healthcare access as followers of faith. Our families depend on our efforts, our kids do as well. We should join together to fight for a healthier valley and a healthier California for all. So today, on the eve of the scheduled vote on Trump Care, we will hear from experts that work in the healthcare field. They are on the trenches, people who have been personally affected by the changes in the healthcare system and therefore better understand exactly what's at stake. I look forward to hearing their testimony, and I'm thankful we're having this right here in Fresno.
Thank you. We'd like to bring our first witness, or so to speak, Brian Metzger with the Legislative Analyst's Office. And please come on up. And Mr. Metzger is the Fiscal and Policy Analyst for the Legislative Analyst's Office, and he's going to give us an overview of what the Affordable Care Act means to California. Mr. Metzger.
Thank you, Chairs. Good afternoon, Assembly members. Brian Metzger from the Legislative Analyst's Office. Our office was asked to provide a brief overview of the impacts of the Patient Protection and Affordable Care Act, or ACA, on California. This overview will provide some context for what is at stake should the American Health Care Act, or AHCA, in its current form become law. A handout was distributed to you that provides federal funding and coverage changes in California under the ACA. On page 1 of the handout, you will see we have organized our discussion today around the 3 major components of ACA federal funding. First, we discuss federal funding for the state expansion of Medicaid program eligibility, commonly referred to as the ACA optional expansion. Second, we discuss subsidized health insurance coverage for qualifying individuals through health benefit exchanges. And third, we discuss additional federal funding for other healthcare programs and services, such as the Children's Health Insurance Program, or CHIP. Our table at the bottom of the page, ACA federal funding to California, provides our most recent estimate of the amount of federal funding that the state is projected to receive. The table quantifies this funding during different timeframes, but in summary, California is projected to receive more than $20 billion annually from the federal government under the ACA. On page 2, we also note that there will be later discussions about the reductions in California's uninsured rate and other changes in health insurance coverage under the ACA. On the next page, we discuss the first component of federal funding under the ACA optional expansion. In 2014, California opted to participate in the ACA optional expansion. This expanded Medi-Cal eligibility to individuals under 65 years of age with household incomes at or below 138% of the federal poverty level. Childless adults were the primary population covered by this expansion. For the first 3 years of the expansion, the federal government paid 100% of the costs for this population. Starting this calendar year, the state is responsible for 5% of the costs. In 2020 and thereafter, the state will be responsible for 10% of those costs. In terms of the impact on California, in 2017-18, federal funding for this population is projected to total $17 billion, or 3/4 of all federal funding the state is projected to receive under the ACA. In terms of enrollment, Medi-Cal's ACA optional expansion caseload is projected to be approximately 4 million enrollees in 2017-18. On page 4, we discuss the second component of federal funding under the ACA, premium subsidies and cost-sharing reductions, or CSRs, available through the state's health benefit exchange covered California. Premium subsidies are federal tax credits provided to individuals between 100% and 400% of FPL, and for whom alternative forms of coverage are not available. We note that in California, individuals between 100 and 138% of FPL would enroll in Medi-Cal because the state opted into the ACA optional expansion. These tax credits are used by individuals to purchase health insurance coverage through Covered California. CSRs are paid to health insurers and are used to reduce the out-of-pocket costs paid by individuals with the lowest incomes. Regarding the impact on California, in 2017, premium subsidies and CSRs are projected to account for most of the remaining ACA federal funding received by the state at $5.4 billion. The state is projected to use $4.6 billion of that funding for premium subsidies and $800 million for CSRs. In June 2016, more than 1 million Californians enrolled in coverage through Covered California. 90% of those received premium subsidies, and more than half received CSRs. On the next page, we briefly summarize the third component of ACA federal funding for other healthcare programs and services. 2 programs are the primary recipients of ACA enhanced federal funding: CHIP and the Community First Choice Option, or CFCO. CHIP provides health insurance coverage to children in low-income families, but with incomes too high to qualify for Medicaid. Under the ACA, states receive an enhanced CHIP funding rate, and this enhanced rate is projected to generate an additional $600 million in federal funding for Medi-Cal in 2017-18. CFCO provides home and community-based attendant services and supports to seniors and persons with disabilities. Under the ACA, states receive an enhanced funding rate, and this enhanced rate is projected to generate an additional $300 million in federal funding for Medi-Cal in 2017-18. The state also receives grant funding from the ACA's Prevention and Public Health Fund for activities like cardiovascular disease and stroke prevention, immunizations and screenings, and tobacco control. While amounts vary year to year, grants to the Department of Public Health and other state agencies are projected to total $60 million in 2017-18. In terms of coverage on page 6, we note the significant reduction in uninsured Californians under the ACA, from 6 million, or 17% of the population in 2013, to 3 million, or 8% of the population in 2015, a net decrease of 50%. The primary drivers of the state's gains in coverage were the ACA optional expansion and subsidized coverage through Covered California. On page 7, we show the variation in ACA-funded coverage by county. While the state's smaller and more rural counties had the highest proportional increases in the number of individuals with ACA-funded coverage, larger counties, such as Fresno, Los Angeles, and San Bernardino counties also experienced particularly significant shifts in coverage. That concludes my remarks. Thank you.
Thank you very much. Any questions? I know you'll be back, so
Yes.
I appreciate that. So we're going to move on to our next speaker, who is Deborah Kelch, the Executive Director for Insure the Uninsured, to talk about insurance market and consumer reforms. Please, whenever you're ready.
Thank you. Good afternoon, Chairman Arambula, Chairman Wood. Thank you very much for inviting the Insure the Uninsured Project to be with you this afternoon. So the Insure the Uninsured Project is a nonpartisan, independent, nonprofit organization that was funded when the federal government failed to pass reform in 1996. So since that time, ITEP has really kept its eye on the ball of what the state can do to reduce the uninsured. So I want to just set the stage a little bit as we talk about what the world was like before the Affordable Care Act. I think sometimes that isn't as present in our minds as we navigate the various proposals that are showing up every 15 minutes on our cell phones. So before the Affordable Care Act, California had high rates of uninsured, hovering around 20% for decades. Employer-sponsored coverage was declining, with employees paying a higher share of costs. Medi-Cal was only available to children, seniors, and disabled, and some low-income parents. Specifically, our pre-ACA individual market, individual coverage was not available at any price for people with pre-existing conditions. They were priced out of reach for most low and moderate income Californians. Many policies had limited benefits, inadequate coverage, and no minimum value standard. There were no limits on consumer out-of-pocket costs. There were limits, often annual and lifetime limits, on the benefits covered. Premium rates were not publicly available the way they are now. There was limited regulatory review of rates and rate increases. Since the ACA has been so fully embraced in California, what we have seen, as Brian suggested, is these dramatic reductions in the number of uninsured, basically cutting it in half. Overall, Medi-Cal enrollment has increased, not just the expansion population, but because of the state's robust outreach and enrollment activities, which I know has been true in this community and many others. There were lots of folks who came onto the Medi-Cal program who had been eligible before but didn't know about it, or it was difficult to apply for. Covered California has enrolled 1.4 million, and the executive director said at their most recent board meeting that's up to 1.5. And this slide, The numbers went away on this slide, but it basically shows the decline in the uninsured. A big portion of our increase in coverage has come through Medi-Cal. So let's talk now about our insurance market under the ACA. So now we know that individuals between 138 and 400% qualify for premium assistance in covered California. We have one of the most successful exchanges, if not the most successful exchange in the country. 90% of covered California enrollees pay for their care with premium assistance. The market rules have dramatically improved. Insurers must cover everyone, regardless of their health status. They cannot exclude payment for pre-existing conditions. Young people can stay on their parents' policies until age 26. There are no annual and lifetime benefit limits. The age rating factor of 3 to 1, as Chairman Wood suggested, is now possibly able to go up to 5 to 1, dramatically increasing premiums for older adults. Essential health benefits has meant that everyone is assured of a basic set of benefits that will cover important health care needs. And for California, we have led the way in standardizing the benefits in the exchange and for mere products outside of covered California. So we know there are lots of proposals and amendments to proposals and suggested ideas, but we do at this time know that Congress is considering the American Health Care Act through a budget reconciliation process so that they will not be required to get 60 votes for that proposal in the Senate. And this means that they can deal with parts of the Affordable Care Act that impact spending, revenue, or the debt limit. So it's apparently now one bill, not two. My slides are adjusted daily, but just to clarify, there is just one bill now. The American Health Care Act does not repeal the ACA relating to Medicare, quality of care, program integrity, workforce, Indian Health Service. It keeps most of the market rules in place, guaranteed coverage, no pre-X, young adults under age 26, but as we'll see later, this has potentially dramatic impacts on premiums and the market stability going forward. The American Health Care Act focuses on repeal and revision to insurance affordability subsidies, Medicaid, individual employer mandates, and taxes. So the American Health Care Act repeals most of the taxes. It does include a $100 billion fund to be known as the Patient and State Stability Fund, which has many possible uses that states can allocate the funds for, including high-risk pools, but also reinsurance, which is another way to deal with the cost of high-cost enrollees, including things such as access to preventive vision, dental, healthcare provider payments, assistance to reduce out-of-pocket costs. Is a complicated formula in the American Health Care Act, and while $100 billion sounds like a lot, that's a national number, so we don't know that we would come anywhere close to being able to address any one of the options available in our state. The American Health Care Act restores disproportionate share hospital cuts that the Affordable Care Act imposed, and imposes a one-year moratorium on federal funds to any nonprofit community providers that perform abortions. So not just funds for abortion, but any funds that they would get. It includes $422 million for federally qualified health centers, again, a national number, which once you realize the number of health centers across the country is not as much as it might seem like. So let's just put the two side by side here in our analysis. So the Affordable Care Act has an individual and employer mandate which the American Health Care Act would retroactively eliminate and instead impose what's known as an late enrollment penalty, what they refer to as continuous coverage, which means anyone who doesn't maintain coverage and doesn't purchase coverage during the open enrollment period would have to pay a 30% surcharge, paying 130% of whatever the premium is. While the American Health Care Act does maintain essential health benefits, it also eliminates the requirements in the Affordable Care Act for insurers to identify their products by their actuarial value. Actuarial value is the amount of the health care benefits that the policy will pay. So a 60% actuarial plan means that the insurer, the policy covers 60%, and the provider and/or consumer, primarily the consumer, will make up the difference, the 40%. So what we have now is we're familiar with these, what have been called the metal tiers, the bronze, silver, gold, and platinum, and those would be eliminated under the American Health Care Act, along with the standards that require insurers to provide value for the products they're offering. And I'd like to say just a few things about why that's really important that those will go away. The first, not insignificant point, is it allows consumers to compare products. So if you choose all the silver products, you know when you're comparing one to the next that the coverage is about the same with little variation. Whereas in the pre-ACA market, you might have 3 products that had similar names, might be $5,000 deductible, but all kinds of differences could occur in terms of the benefits covered, the way the benefits are apportioned, the cost sharing, and it was almost impossible for consumers or employers to compare those products. And finally, California did more in this area than other states by standardizing benefits through Covered California, by requiring health plans that don't participate in the exchange to also make available products that mirror those standard benefits. We've done a lot in our California law to really stabilize the market and reinforce the viability of the exchange. These things could be removed in the federal law, leaving California to address it in state law. So again, the 5-to-1 ratio, the ACA premium tax credits will be changed initially so that it would change the percent of income that younger and older purchasers would have to pay, decreasing the percent for younger workers and increasing the percent for older purchasers. It eliminates fully the tax credits in 2020 and replaces them with age-adjusted fixed dollar tax credits ranging from $2,000 to $4,000. As LAO mentioned, eliminates the cost-sharing reductions that reduce out-of-pocket costs and prohibits the use of tax credits for any product that covers abortions. So what we know is the wisdom of the Affordable Care Act was that the tax credits varied with the premium, which in California, the premiums across the state, north, south, different communities vary dramatically. So the premium tax credits under the ACA reflect those differences in premium. However, the new American Health Care Act's tax credits, so far, are fixed dollar amounts only adjusted by age, not income, not geography, not premium. So what we know, looking initially at the potential impact of the American Health Care Act, is that individuals in most counties, the lowest income, 250% and below, will definitely receive lower tax credits than they do under the Affordable Care Act. Individuals at 300% of the federal poverty and above will get potentially higher tax credits under the American Health Care Act, except for older Californians, older adults. Because premiums increase with age, in most California counties, older Californians making $50,000, or approximately 400% of the federal poverty, are going to be getting less, or they receive higher tax credits under the Affordable Care Act than they will under the new American Health Care Act. So we have displayed for you the Kaiser Family Foundation analysis so we can see what that means, understanding, if you will, that these premium levels are current premium levels. And as we'll talk about in a minute, the Congressional Budget Office has said that premiums will actually go up in the first few years with the American Health Care Act. So it will get potentially more difficult. But as you can see on the left, the current tax credits vary by premium, which between the counties listed there, Shasta and most of Northern California actually, Imperial and Fresno, the current tax credits and the current premiums are higher than on the right, the American Health Care Act tax credits we will see. So basically for low-income folks across the board, regardless of where they live and what they will experience a difference between what the Health Care Act tax credit is and what they actually have to pay for premiums. It won't be enough. For a 27-year-old with $30,000 worth of income, the tax credit does adjust up, but as you can see, there's still many areas of the state where the tax credit is lower than the premium. And again, thinking about adding a 15 to 20% increase on top of this, potentially those areas that look like they would do okay now would be disadvantaged ultimately after those increases occur. A 40-year-old with $30,000 of income, the tax credit goes up, but again, so do the premiums. And so we still see these major discrepancies between what would be provided in the new American Health Care Act and the actual premium. For 60-year-olds, the difference is much more stark and dramatic. So we see older Californians really experiencing a significant gap from what they receive in a tax credit and what they will have to pay for premiums. So this just is a further illustration showing so many of the areas of the state where, in the blue areas, where there's such a dramatic difference in what people will receive under the American Health Care Act. And again, here for 60-year-olds, just looking out to the left, just see at 40,000 income, they will really be disadvantaged again in terms of, and that's a pretty relatively high income, they will still be disadvantaged under the American Health Care Act. So the Congressional Budget Office did an analysis. I just want to put a few highlights up there for you. So they did say that by 2018, that's next year, 14 million Americans would lose coverage, and it would grow to 24 million by 2026. And this is a really startling number. By 2026, 52 million Americans would be uninsured, compared to 28 million if the ACA remained in place. So obviously we still had our work cut out for us. We still had people to get to under the Affordable Care Act. But note that the 52 million number is higher than the number of uninsured before the Affordable Care Act, which was 45 million. So the CBO also said that despite repealing all the ACA taxes, there would be a potential $337 billion in savings to the federal government, which really just reflects this dramatic reduction in Medicaid. I know Western Center is going to be talking about Medicaid, but this dramatic reduction in Medicaid and in health insurance subsidies. They also said that premiums would go up 15 to 20%. And this is in part because healthy people will opt out once the mandate is removed. So this is really important in terms of looking forward. So CBO did find eventually the premiums would go down by 10% a year. But we need to think about and understand why that is. First, the value of the coverage will go down for two reasons. There will be no standards. The metal tiers go away. Health insurers can sell products that don't have any standard value. And secondly, once people's premium tax credits go down, they're going to be looking for products with higher deductibles, so the premium will be lower and find themselves with much higher out-of-pocket costs. But when you're just measuring premiums, they will be going down. And in addition, over time, there's a strong, the CBO found that younger, healthier individuals would opt out. And so eventually, they would, the premiums would go up, and then with all these changes in terms of the value of the product and the, the value of the product and the shift in enrollment would create this reduction in premiums. Brookings and USC Schaefer Center looked at this question. So if you keep the value of products constant, in other words, the benefits don't deteriorate, and if you keep the current age mix that we have now, actually, under the American Health Care Act, the premiums would go up 13%. So we really have to make sure we're having apples-to-apples comparisons. So everyone, including us, is reading the new amendments, which just came out. A few highlights. The tax credits would no longer be available for unsubsidized COBRA coverage. It appears that a proposal that would have allowed people who had an excess tax credit where their premium was less, they could have, under the original version, put the money into a health savings account. That appears to be gone. In establishing procedures to advance tax credits, there are additional requirements that HHS and IRS require robust verification of eligibility. It also repeals the ACA increase in the medical expense deduction with the intention of providing tax relief to older, lower income individuals. But if you don't have to pay taxes, a tax deduction is not a meaningful benefit for you. There's also language suggesting that it is in this area where they're making available some additional revenues that they would encourage the Senate to improve the tax credits for older individuals, but the details are not yet known. It does accelerate, the amendments do accelerate repeal of ACA taxes to 2017 instead of 2018. So I just want to close with a couple of kind of high level. There is a lot of data, there's a lot of information, there's a lot of numbers, there's a lot of proposals. But what we know to be true is we have decreased our rate of uninsured in the state to a historic low. We also know we can't say today exactly what's going to happen because the proposals are still in flux. But here's what we do know. If you look at what CBO said, it appears entirely likely that if the American Health Care Act as we see it today is fully implemented, the state could return to 5 to 7 million uninsured. That's the big picture. Also, I thought this was really striking. So we don't cover people to say we covered people. It's not entirely about their access to health care. We also do it so we can improve health. That's the end goal. So the Commonwealth Fund just came out with their scorecard on state health system performance for 2017. And this was just, we were just really impressed in our office because California went on a series of measures from 26th place among the state to 14th. And look at these numbers. On every measure, or on most measures of adult health, we see these dramatic improvements in the period between 2013 and 2015, which is our early implementation of the Affordable Care Act. So we see a rise in the number of adults with the usual source of care. We see adults who went without care because of cost, the number drops. We see at-risk adults with without a routine doctor also dropping. We see adults who report fair and poor health because of physical, mental, or emotional problems dropping. We see adults with age-appropriate vaccines increasing. And we see the number of adults who smoke decreasing. So this is what's at stake. The numbers and the data notwithstanding, this dramatic improvement, which has only just begun under the Affordable Care Act, is really what's at stake for California when we think about the repeal and replace conversation that's happening at the federal level. So thank you again for your time today, and I'd be happy to answer any questions now or during the hearing.
Good. Thank you very much, Deborah. Any comment or question? Thank you. We may have questions for you later. Appreciate that. Next, Jen Flory is going to talk to us about Medicaid, Medi-Cal. Jen is a policy advocate for the Western Center on Law and Poverty. Thank you.
Good afternoon. I've been asked to cover some of the other parts of the American Health Care Act that affect our Medi-Cal program. I think later speakers will cover more of some of the macro effects on the financing of Medi-Cal, so I'll cover some of the program effects that affect the beneficiaries. In 2014, California rolled out its implementation of the Affordable Care Act. Not only did we expand Medi-Cal, our state Medicaid program, by allowing adults up to 138% of the federal poverty level who were previously ineligible to enroll, we also made key program simplifications that led to ultimately more than 14 million people being covered by our Medi-Cal program. The idea behind program simplifications was no wrong door. We created a single application for insurance affordability programs so that someone wouldn't have to know whether they should get Covered California, Medi-Cal, Healthy Families, or AIM for pregnant women. They would just apply and get coverage in the appropriate program. Many of our programs have since been consolidated under Medi-Cal, so enrollees have the same networks regardless of what program they're in. We also simplified the application process. Many of the verifications that were needed, citizenship, immigration status, identity, income, are now largely handled with electronic databases that can verify the income in real time. This means that people can apply even when they don't have all of their documents in hand, often get an instant eligibility result, and can begin using care. Finally, California also opened up other channels of enrolling, such as through the Hospital Presumptive Eligibility Program. This program allows patients to supply minimum information about income eligibility, later filling out the rest of the application, and immediately get approved for care without worrying about going into debt or bankruptcy due to a large hospital bill. The proposed American Health Care Act attempts to undo this program simplification so that our guiding principle of no wrong door becomes no right door for Californians living in poverty. The AHCA would stop the Hospital Presumptive Eligibility Program so that adults cannot get fast-tracked onto care when they need it most. In this age of disinformation and alternative facts, many people still do not know that they are Medi-Cal eligible until they are screened for it when getting emergency care. The AHCA would end the rule that allows Medi-Cal applicants to submit older bills when applying for care if they would have been eligible at that time. This is an important tool against medical debt that is often used when people get hospital care but cannot actually apply until they are stable enough to submit an application weeks later. The AHCA would impose a new requirement that citizenship or immigration status must be proven prior to getting care or the federal government won't pay. California verifies citizenship and immigration status electronically through federal databases. When these databases are not functioning properly, it is not the fault of the applicant, and we should not make them delay getting care while sorting out this documentation. A decade ago, when California implemented a stricter citizenship documentation requirement mandated by Congress, the result was that administrative costs went up, and some people experienced delays in accessing care, but no savings were found by rooting out suspected fraud. The AHCA would also make some applicants renew their Medi-Cal twice a year, rather than one time as we do for all other health coverage programs, just in the hopes that some people will not turn in their paperwork and will lose their coverage. The administrative burden of having a different renewal process for some groups of people also presents other challenges that will drive up workload in the counties. The new AHCA amendments allow states to impose a work requirement, putting more conditions on receiving health care and ignoring the reality that many Medi-Cal recipients are working, they just don't have health care. For many recipients who are not working, it is their health that prevents, and only by securing their access to health care can we get them back into the workforce. The AHCA would also eliminate enhanced funding to the Community First Care program that allows some of our sickest Medi-Cal recipients to get home-based care rather than forcing them into institutions. This is not only cruel, but it can be more expensive in the long run. The AHCA lowers the cap on home equity by $250,000 for people who need nursing home care. This means that some seniors in parts of California with high home prices would be forced to sell their homes and spend down before getting the care they need. As other speakers will explain, the AHCA also imposes a per capita cap on Medicaid spending, meaning that over time, California will have less money for its entire Medi-Cal program. New amendments, specifically the block grant amendment, give states the option of taking a lump sum of money to cover children and parents that is further capped in exchange for so-called flexibility. This option is only viable if California creates a different Medi-Cal program that is less than the program we have now. In other words, rather than integrating many of our low-income health programs into Medi-Cal, we will be turning Medi-Cal into a variety of programs with different benefits for different people. Some people would get full benefits, while children and parents would get a pared-down program. This is not the flexibility we seek in California. Furthermore, the block grant option does not undo many of the most administratively burdensome pieces of the federal Medicaid dollars, such as the additional barriers to enrollment that I just mentioned earlier. And finally, the AHCA seeks to phase out the Medi-Cal expansion by squeezing federal dollars out of it and putting the coverage of 3 to 4 million Californians on Medi-Cal at risk with no affordable alternative. To sum up, the American Health Care Act proposes saving money by cutting millions of very low-income Americans off Medi-Cal. It also aims to save money by preventing eligible Americans from getting Medi-Cal by enacting additional barriers to enrollment, and has provisions that push low-income seniors who are very sick out of their homes. And what do we get for all of these savings? A tax cut for the richest Americans. If saving money by taking care away from the poor to give tax cuts to the rich is what American health care is, then we've really lost our way. In closing, others here will speak more eloquently as to the personal effects of the Affordable Care Act in their lives. As a legal services advocate, one of the most profound changes that the Affordable Care Act brought is that we would no longer need to tell adults without dependent children that Medi-Cal couldn't help them, no matter how poor they were, until they were too sick to work. One client that will always haunt me is one who came to Western Center with an early diagnosis of colon cancer. There were not programs or resources in her county that could help her get the treatment that she needed, and Medi-Cal denied her as she was not yet disabled. Finally, when her cancer progressed to stage 4 and she was no longer able to work, she was able to get on Medi-Cal. I would hope that as a society, we would not want to return to such a time of needless human suffering. Thank you.
Thank you. Thank you. Mr. Metzger, you're back. Mr. Metzger is going to talk to us about Medicaid per capita cap allotment program, and then the Congressional Budget Office analysis of the new not Affordable Care Act.
Thank you. Our office was also asked to provide an overview of the per capita capped allotment structure proposed for Medicaid by the American Health Care Act, or AHCA. We provided a second handout that was distributed to you that provides an overview of relevant provisions from the law related to Medicaid per capita caps, as well as some key budgetary considerations in light of this proposal. First, it is important to note the extent to which California currently relies on federal funding for its Medi-Cal program. In 2007-8, federal funding for Medi-Cal totaled $22 billion. In 2017-18, federal funding for Medi-Cal totaled $67 billion, or 2/3 of all funding in the program. On the next page of our handout, we note that the AHCA would change major provisions of the ACA, including enhanced federal funding for the ACA optional expansion. Under the AHCA, the federal government would continue to pay 90% of the costs of ACA optional expansion individuals who are eligible under current law and who enroll prior to December 31st, 2019 into 2020 and beyond, unless and until they lose Medicaid eligibility for 1 or more months. If those individuals re-enroll, the federal government would only pay its traditional share of costs, which in California is 50%. The federal government would pay the same share for individuals in the ACA optional expansion who newly enroll on or after January 1st, 2020. As we note on page 4 of the handout, the AHCA would also transition Medicaid from a federal entitlement program into a per capita capped allotment program. As an entitlement, the federal government currently pays its share of costs, regardless of enrollment or incurred costs. As per capita capped allotments, the federal government pays annual allotments based on historic Medicaid spending that assumes a certain federal state cost share, and any expenditures in excess of those allotments must be fully paid by the state. The AHCA identifies 5 enrollment groups for calculating these allotments: elderly, blind and disabled, children, optional expansion enrollees, and other non-elderly, non-disabled, and/or non-expansion adults. The caps for these groups would be calculated using their average historic Medicaid expenditures and allotments determined based on the current number of enrollees. Caps would increase each year by the percentage point increase in what is called the medical component of the Consumer Price Index, CPIU medical. Recent amendments to the AHCA would provide an additional percentage point increase for the blind and disabled, as well as the elderly enrollment categories. Any expenditures in excess of the allotments would not only be the responsibility of the state, but would also trigger an allotment reduction. On the next page, we provide 3 key budgetary considerations in light of this proposal. The first consideration is the extent to which ACA optional expansion enrollees in California lose their Medi-Cal eligibility in and after 2020. As stated previously, if an enrollee loses his or her eligibility for 1 or more months, the state receives 40% less for that enrollee's cost should he or she re-enroll. The Congressional Budget Office, or CBO, projects a significant amount of churn, quote unquote, nationwide in this population. By the end of 2022, fewer than 1/3 of these enrollees are projected to be enrolled, and by the end of 2024, they are projected to be fewer than 5% left. Should California see this level of churn, it would lose billions of dollars in enhanced federal funding for the pre-2020 optional expansion population by about the mid-2020s. The second consideration is whether CPI-U Medical covers increased Medicaid spending. The Centers for Medicare and Medicaid Services, or CMS, projects total Medicaid spending will increase at about an annual rate of 6%, whereas CPI-U Medical is expected to increase at about 3 to 4%. While a small difference in percentage, this could represent billions of dollars between what California's capped allotments provide and what the program spends that the state would then have to cover. And the third consideration is whether supplemental payments would be included in the per capita Medicaid expenditures. Should 1115 waiver funding, for example, be considered supplemental expenditures and excluded from per capita capped allotment calculations, federal funding for Medi-Cal could be reduced. Finally, we would note that recent amendments to the legislation provide states the option to receive federal Medicaid funding as a block grant instead of a per capita capped allotment. Under a block grant program, the state would receive a total allotment of federal funds. By comparison, under a per capita allotment program, the state would receive an allotment of federal funds per Medi-Cal enrollee. Under either a block grant or per capita allotment program, a base year of federal funding would likely be established, after which a growth factor could be applied in subsequent years to account for increases in healthcare costs. However, under a block grant, the state would bear the additional costs of increases in caseload, while the state would benefit from federal Medi-Cal funding not declining if the Medi-Cal caseloads were to decline. A per capita allotment structure would mitigate some of the risks to the state associated with the block grant structure, since federal Medi-Cal funding would vary based on the number of Medi-Cal enrollees. That concludes my remarks on Medicaid per capita caps. Just go ahead. All right, thank you. Our office was also asked to provide a brief summary of the findings from the CBO's analysis on March 13th of the AHCA. Though we focus our remarks on the projected reduction in the federal deficit and increase in the number of uninsured, we acknowledge that there are a number of other topics covered in the analysis, including the legislation's effects on the stability of the insurance market and on health insurance premiums, which Deborah covered earlier. We also acknowledge that another CBO analysis is forthcoming that will score amendments made to the AHCA on Monday, and that analysis is not included in my remarks today. On the last page of the same handout, you will see our quick recap of the CBO analysis. First, the CBO estimates that AHCA would reduce federal spending by a net $1.2 trillion over a 10-year period. Most of these spending reductions would come from converting Medicaid from a federal entitlement to a per capita capped allotment, an estimated reduction in spending of $880 billion, and from eliminating the ACA's premium subsidies and cost-sharing reductions, an estimated reduction in spending of $673 billion. These spending reductions would be partially offset by the AHCA's new tax credits, which would increase spending by an estimated $361 billion. However, the AHCA would also reduce federal revenues authorized by the ACA by $900 billion over 10 years, primarily from the elimination of individual and employer mandate tax penalties, taxes on high-income earners, and the fee on health insurers. Taking these changes together results in a projected $337 billion reduction in the federal deficit over 10 years. Finally, the AHCA would increase the number of uninsured by an estimated 14 million individuals nationwide in 2018, 21 million in 2020, and 24 million in 2026. We note that of the 24 million in 2026, 14 million would be Medicaid enrollees, or 17% of the projected Medicaid population nationwide. Today, the Department of Healthcare Services released an analysis of the proposed legislation. They found that the state share of costs in federal funding would be reduced by $6 billion in 2020, up to $24 billion in 2027. Of that, in 2020, $4 billion would be general fund dollars, and in 2027, it would be $19 billion from the general fund. They also assume that the CBO's estimate for churn in the program would also apply to California for the ACA optional expansion, which would eliminate nearly all of the enhanced federal funding for the ACA optional expansion. And they also provide current projections of Medi-Cal expenditures and growth that in the cap that could lead to spending above the cap. But this assumes no changes currently in the program, so there would be potentially changes in the future. And that concludes my remarks. Happy to answer questions.
Thank you. First of all, thank you, Mr. Metzger. I just want to hit on something, and you don't need to stay there if you don't want to, but I just want to hit on something. This report that actually just came out today from Department of Healthcare Services, the final paragraph, I think, has a sentence that's really, really important and really important to understand. The current proposal represents a massive and significant shift in funding from the federal government to states. And a lot of this is actually going to be funded by tax cuts on really wealthy Americans. And that is a significant frustration for me personally, as we see the people who will be affected the most will be the poorest and the most vulnerable. When you look out into the future, that $19 billion a year that we would be in the hole, so to speak, to put that into perspective for you, when we actually had the budget deficit in the deepest part of our recession, that was close to $26 billion. That was a budget deficit that we took years to work out of. We're now looking at potentially $19 billion shortfall a year by this shift. So this is extremely significant, and really going to have a huge impact on so many Americans should this go through. So our next speaker, Laurel Lucia, is going to talk about the loss of coverage and economic impact. She's a manager for the healthcare program at the UC Berkeley Center for Labor and Research Education. Thank you so much, Laurel.
Hi. Thank you for the opportunity to present our research today. To start with, I'm going to, thank you. Several of the other speakers have talked about the historic drop in uninsurance in California under the Affordable Care Act. We don't yet have California-specific estimates under the AHCA of how uninsurance would change, but we know from the national estimates from the Congressional Budget Office that we're talking about at least going back to pre-ACA trends in terms of uninsurance. Next slide, please.
Before you go, I just want to welcome Assemblymember Miguel Santiago, represents the 53rd Assembly District in the Los Angeles area. He's a member of our Assembly Health Committee. Please go ahead, thank you.
This morning we released a new study that looks at the impacts of the AHCA on California's Medi-Cal program in terms of coverage and funding. And I'll explain all of the numbers that are up here on this slide, but as background, as Brian described, under the Affordable Care Act, the federal government pays 90% of the costs for expansion enrollees. And what's proposed under the American Health Care Act is that the federal government would continue to pay that 90% rate for people who enrolled before 2020, as long as they don't have a break in coverage of more than 1 month. And for new enrollees, the federal government would pay a much lower share of 50%. And based on previous research and administrative data, we know that there is significant churn among Medi-Cal enrollees out of the program and often back into the program due to fluctuations in income and also due to factors that are not related to changes in eligibility, like they may move and not receive their renewal packet, or they may encounter other difficulties in the paperwork process. And so very quickly, within a couple of years, the majority of enrollees in the expansion would be paid by the federal government at that lower 50% matching rate. And so there would be a big cost shift to the state, as we've been hearing. We estimate that the state would need to spend $10 billion more per year by 2027 in order to maintain the Medi-Cal expansion at its current level. Now, given how challenging it would be for the state to find $10 billion, we also examined a scenario in which California decides that it can only afford to continue coverage for those who enrolled by 2020 and would close the program to new enrollment. Starting in 2020. In reality, the state may do something in between those two options, but we wanted to show the range of impacts. So if the state closed the program to new enrollment in 2020, we estimate that 3.7 million fewer Californians would be enrolled in Medi-Cal by 2027. And we were conservative in our enrollment assumptions under current policy, so it could be more. This loss in Medi-Cal enrollment translates to a significant loss in funding to our healthcare system within the state. By 2027, our healthcare system would receive nearly $25 billion less in terms of total federal and state Medi-Cal funding, which would affect healthcare providers' financial stability. In our study, we also included impacts by county and congressional district, along with California Senate and Assembly district. To give one example, here in the San Joaquin Valley, when you aggregate the San Joaquin Valley counties, we project that this region would lose 465,000 Medi-Cal enrollees by 2027 and $3 billion to the local healthcare system under the American Health Care Act if the state closes the program to new enrollment. Next slide. So I want to step back and provide a little context for who these Californians are who could lose coverage, who are currently enrolled in the Medi-Cal expansion. Enrollees are disproportionately people of color. 71% of enrollees are, compared to 62% of the California population of the same age. They're generally workers. Nearly half are working. Another 12% are actively looking for work. And the remaining adults, some of them may have working spouses. Our research shows that that workers in certain industries have higher rates of enrollment in the Medi-Cal expansion. Workers in agriculture, the restaurant industry, retail, other service sectors like auto mechanics and hair salons, and also janitors and security guards. All of those industries have higher than average enrollment in the Medi-Cal expansion and would be disproportionately harmed if that program is cut. We also have found that certain regions in the state rely more heavily on Medi-Cal overall, and the Medi-Cal expansion in particular. In some counties in the state, including Fresno right here, half of the population is enrolled in the Medi-Cal program overall. In terms of the Medi-Cal expansion in particular, roughly 1 in 10 Californians is enrolled, but in the northern part of the state, there are certain counties like Humboldt and Mendocino which have much higher enrollment. And here in the San Joaquin Valley, in Fresno County, Kern, Stanislaus, Tulare, enrollment rates in the Medi-Cal expansion are higher than average. Now turning to Covered California, 1.2 million are enrolled in subsidized coverage through Covered California, and premium subsidies average $5,300 per year for households and $3,500 per individual. Now, half of the enrollees who get these premium subsidies also get financial assistance with co-payments and deductibles. That financial assistance averages $1,500 per year per household, or $1,000 per individual. Under the American Health Care Act, the premium subsidies would be less generous for many people, and I'll provide some examples, but they would be more generous for some. But the American Health Care Act also would completely repeal the assistance with cost sharing and not replace it with anything. And that assistance would be especially necessary under the proposal because the Congressional Budget Office estimates that individual market enrollees would be enrolled in plans in which the insurers pay less on average than they currently do. We don't yet have estimates of how many of these 1.2 million covered California enrollees would continue in individual market coverage given the change in subsidies. But we know from the national estimates from the Congressional Budget Office that initially the individual market would shrink substantially due to the higher premiums. Over time, the individual market would grow back close to what it would be under current law, but that's because the CBO projects that fewer people would be in job-based coverage under the proposal, and those people would be in the individual market. So the individual market would be slightly smaller, but have a much different composition. It would likely have more young people and more high-income people, which my next slide will help to illustrate why that is. Deborah talked about some examples in terms of how the subsidies would change under the American Health Care Act. Covered California has released comparisons for each of the regions in the state. These numbers are hard to read up here, but these numbers are for Fresno, Kings, and Madera counties, which are all one region for Covered California purposes. So just to summarize what's up there, low-income people earning $17,000 and more middle-income people earning $30,000 a year would all pay more under the American Health Care Act here in this county, regardless of their age. Now, the impact compared to the Affordable Care Act would be much worse for older people. A 62-year-old earning $17,000 would pay $8,700 more per year in premiums under the American Health Care Act. And that's because premiums are higher for older people, and the proposed subsidies take that into account to a limited extent, but they don't fully account for the premium differences by age, whereas the Affordable Care Act does. And then higher income people earning $75,000 would all pay less under the American Health Care Act because the Affordable Care Act subsidies don't go up to that income level. So moving to the economic impacts, in December we released a study about how ACA repeal could affect employment and the economy in California. And we estimated that California could lose 209,000 jobs under the repeal of the Affordable Care Act. And the way that would happen is California has received $20 billion in federal funding for the Medi-Cal expansion and Covered California subsidies under the Affordable Care Act. And that has supported the tremendous gains in health insurance that we've talked about. From the research, we know when people have health insurance, they use more healthcare services, especially preventive services and mental health care services. And so with that increased demand for healthcare services, hospitals and clinics have staffed up, and if that funding goes away or if it decreases, many of those jobs would go away in the healthcare industry. But when healthcare workers have less income, they spend less in their local communities, at restaurants, at other local businesses, and so there's a spillover effect that would happen to other industries beyond healthcare, which would also lose jobs, and that's included in our 209,000 estimate. Now, when we did this estimate a few months ago, it was before, the American Health Care Act was proposed, and so there are some differences in what we assumed in terms of what ACA repeal would look like. Given the differences, we assume that this job loss would still occur, but it would occur somewhat more slowly. By approximately 2024, we project that California would lose these 209,000 jobs, and that job loss could grow further over the years. Just as the San Joaquin Valley is especially at risk for health insurance losses, we provided the job loss estimates by region and found that the San Joaquin Valley stands to lose 24,000 jobs if the ACA is repealed. That's more jobs than were estimated to be lost statewide due to the drought in 2015. 21,000 jobs were estimated to be lost due to the drought. So overall, in conclusion, our research indicates that California would experience significant and severe coverage losses, funding losses to our healthcare system, and economic losses if the American Health Care Act is enacted.
Thank you much.
So I just wanted to thank Ms. Lucia for bringing that information forward and how pertinent it is for you to set the table for us to now transfer into the next section that we're going to have. So I wanted to thank everyone in the audience for being patient. We're trying to deliver information, and next we're going to have consumers, people who are actually benefiting from the ACA, come forward and discuss their stories. So I'd like to invite J.C. Aguirre, Natasha Mosaiev, and Florence Croson to please come forward to the front.
I'm a little bit short-winded and try again. Okay, we're a go. Start off by wanting to thank both the chairs for hosting this hearing today because it's really important. I almost say this with a sad feeling and almost devastating effect on my own soul because it's unfortunate that we're actually having this conversation where it's clearly the policy being pushed at the federal level is not a good policy for any working families or people in general. And while I may refrain from how I really feel or what I'd like to say, though, is it's pretty obvious that it's the politics of what they're trying to do. And pardon me for going a little bit too far on that, but quite frankly, when you begin to put money above people, there is a real problem in our government and in the approach to how we do policy. Because if you take a look at what Trump Care is, or Ryan Care, however you want to call it, the AHAC, at the end of the day, we're going to have millions of people in California without health care coverage. And I don't care which way you slice it, because none of us ever ran for office to try to figure out how to take health care away from people. And none of us ever ran assuming that we're going to do the massive tax cuts on the wealthy at the expense of poor people who are going to lose health care. And when we have a neutral arbitrator like the CBO come out and say we're going to have 24 million people not have health care coverage, and you still proceed to want to talk about legislation that is going to take away 24 million people's health care coverage, there is something absolutely wrong with the direction that our colleagues in Congress are doing, and quite frankly, the Republican congressional delegation is pushing, because I can't imagine that I could go back to my district and vote against something that is going to have such a devastating and horrible effect on people. And And it's heartfelt for me to sit here and have to have a conversation about how people are going to lose health care coverage. And at some point in time, we ought to really ask if one life is worth that vote, or hundreds of thousands of lives are worth that vote, because we know that ultimately, if this were to pass, people will lose their lives if they cannot get the medicine or the medical coverage that they have. And I want to thank you for giving me the opportunity to speak, but at the core of this really is we've got to send a strong message to our congressional delegation here in California that this is absolutely unacceptable. Unacceptable that close to 5 million people in California will lose health care coverage. Unacceptable that 24 million people in the United States will lose coverage. So I'm glad that you're having this hearing, because at least people now have the information. And if the congressional leaders in California decide to proceed forward and to vote on this, that they will be held accountable, because we will hold them accountable for the loss of coverage and for the loss of lives in this state. So thank you, Mr. Chairs, for having the courage to put this together.
Thank you, Assemblymember Santiago. I'd like to start with J.C. Aguirre from Atwater, please.
This thing, okay, yes, it is on. Now, bear in mind that I wrote this to the congressman, so some of the stuff in here is in context to the congressmen themselves. My name is J.C. Aguirre. I'm a 14-year-old student at Merced Scholars Charter School in Merced. The reason I'm here today is because I'm a child with a serious and complex medical condition, and I wanted to express my deep concern about the threats that are posed to my health care by the proposed American Health Care Act, or AHCA. I'm worried that significant cuts to programs like Medi-Cal and Covered California, as a result of a potential drop in federal funding support proposed in the AHCA, will hurt children like me. The decisions that are being and will be made in the next week or so will affect my entire life. We, as youth, have the right to be a part of the process that will affect so many of us in such a profound, far-reaching way. The American Health Care Act, as it stands now, could be very devastating for children like me with serious health concerns. But unfortunately, no one is talking to us about it. There needs to be time allowed for input from people who are directly affected by this proposed Health Care Act, so that these issues that are a problem can be corrected. If we are not part of the process and are unable to have any input on the national level, how can we be certain that we will be safe? After I reviewed the AHCA bill, I saw that it would completely restructure the way Medicaid works, as previous speakers have mentioned. The bill, which would remove billions of dollars from the Medicaid system, would leave states and families like mine to shoulder the burden of health care costs. The state of California would be forced to choose between cutting kids' health care coverage or cutting benefits for seniors, which are both very vulnerable populations. This bill would create a shortage of funding if the state of California decided to cut kids' health care coverage. It would create a shortage of funding for fragile children who need it most. My mom and I make about $1,300 a month, and we can't afford a car or TV, so how can we possibly afford additional medical expenses? In the Central Valley, nearly 2/3 of children total are covered by Medi-Cal. In my county alone, 51% of the population is covered by the Medicaid system. It's already underfunded, and where I live, doctors are reluctant to take Medi-Cal. Of those who do, it's even harder to find willing providers who are qualified or have the experience to care for children like me. This, coupled with the upcoming California Children's Services, or CCS carve-in, planned by the state of California, will make it virtually impossible for us to get the specialty care that children like me need. I have a deformed heart as well as malformed vertebrae in my neck. These birth defects put me at risk for organ system failure. Without being able to readily see the healthcare providers that I need to see, my life is in danger. And truly, I am frightened that this drop in funding, this drop in federal funding support, will only make things worse and cause a drop in the standard of care that I'm currently receiving. I could quite possibly die as a result of this shortage in funding. If this bill is passed, I will be forced to focus more of my time on my health care and less time on my education and future and becoming a successful member of society. Kids who have good health care coverage do so much better in many ways. Better grades in school, better overall health, and better job opportunities. Thanks to Medi-Cal and the California Children's Services Program, I have been able to achieve much, including being able to speak here in front of you today, and it's touching to me. Just last Friday, I took my college placement test. Thanks to the health care that I've received from Medi-Cal and the California Children's Services Program, I'll be able to take trigonometry at my local junior college while completing high school at Merced College Charter School. Thank you. We need to be a part of the process when considering these changes to health insurance coverage for so many people and millions of children, especially. That's why I'm urging our members of Congress to allow time and input from the people who would be most impacted by changes in our healthcare system, instead of creating a whole new set of problems. I'm in pretty good shape right now, but I need ongoing health care to stay that way. Unfortunately, I was born one big pre-existing condition and will be labeled one for the rest of my life, which makes it difficult for someone like me to get affordable health care coverage. If our elected representatives on the national level do not protect health care, every dollar that I earn in the future will go toward my health care costs. This will be a great barrier and make it difficult for me to live up to my full potential, hindering me from achieving success in my big dream of becoming a doctor or working for the CDC. The decisions that will be made will affect the elderly all the way down to infants who can't even speak for themselves and their health care. They will also impact not only my generation, but many generations to come, and that is something that we must deeply consider before rushing to make changes. Thank you very much. In closing, I would like to say that I believe you would agree with this, that it is easier to provide maintenance care under the Affordable Care Act than it is to provide repair care under the American Health Care Act. Thank you very much.
So I think I'm like many of you and are impressed with both the advocacy and intelligence of this 14-year-old gentleman, and just want to give him one more round of applause, please. I'd like to next recognize Natasha Moiseev. Please introduce yourself.
Thank you. Is this working? Hi, my name is Natasha Moiseev, and I live here in Fresno. I'm a graduate of Yale University and UC Davis Law School, and I work as the lead family law facilitator in Merced at the Superior Court there. I'm here today to tell you why removing the financial caps for pre-existing conditions and mandating continuous coverage at the same time is a terrible idea that hurts real people like my family. I'm coming from the point of view of your mom here.
Okay.
My family of 4 suffers from late-stage Lyme disease. We were diagnosed about 10 years ago. The treatment is expensive and long. It ravaged my 2 daughters and my husband, who was out of work for 3 years because he was unable to get out of bed. I became unemployed at that time too because it was 2008. So in 2008, we began our decline from an upper middle class Silicon Valley family to a homeless family devastated by medical bills and insurance costs. When my husband stopped working, we had his COBRA insurance for 18 months at a family cost of $1,800 per month. When that ran out, California had, thank God, put into place a new law that required the insurance company to continue our coverage for another 18 months. We were living in my parents' basement at that time, and I was giving my kids IV treatment twice a day. Unfortunately, the insurance company was required to give us insurance for another 18 months, but there was no cost cap. Our insurance nearly doubled in price, covered much less, and included high deductibles. Yet in order to remain insurable, because at that time there was no Obamacare, we had to have continuous coverage. No other insurance companies would insure us. The ACHA promises a return to those conditions with the simultaneous provisions for continuous coverage requirement and the loose restraints on the price that pre-existing coverage would allow. We were lucky. We have a treatable disease, a family who can house us, and savings and retirement plans that we could deplete entirely for medical costs. My husband and I are now back at work, with the means to rebuild our lives and our finances. But what happens to people who are not that lucky? The Republicans suggest that only lazy poor people have a problem with insurance coverage. Everyone would have the possible situation that we did, where they would have to choose between no coverage forever or expensive nominal insurance with no meaningful coverage. Having maxed out our credit cards, we've finally paid off our medical bills this year. And we have started to save for retirement once again. I'm 52. Because it combines the worst of all worlds, the ACHA is just wrong. I am dogging my Congressman, Devin Nunes, pretty much daily, to no effect. And because I suspect you'll have about as much effect in changing his mind if you put in a word to him, I'd just like to say that if the ACHA passes, I urge you to lead the way in California in creating some kind of program that will limit its damage. Thank you.
Thank you, Natasha. Next, we have Florence Crozen from Merced, and would love to hear your story as well, please.
Good afternoon. As you said, my name is Florence Croson. I'd just like to make a little correction on the last name. It's O-N, not E-N. Just saying. I was born and raised in Merced, and I work as a home care provider for the IHSS program. And I work for my mom. She has severe COPD, which is, she only has like 22% of her lung capacity, so sometimes it's really a struggle for her to even just live. And it's a life-threatening lung disease, and she's also diabetic, and she's insulin dependent. If I did not care for my mother, someone else would have to take care of her, likely a nursing home, which would be much more expensive to the state. I also provide respite care for a family with 3 adult children with Down syndromes. And for over 40 years prior to the ACA, I didn't have health insurance of any kind. And in fact, I can't remember the last time I had health insurance until now. So thanks to the ACA, I qualified for Medi-Cal, and I was able to get to see a doctor and get checked out for the first time in almost 40 years. It's a long time. So I was diagnosed with a thyroid issue, and also I was diagnosed with diabetes. So I'm on medication now to control my blood sugar, and if it had gone untreated for longer, who knows how bad it could have gotten. My worst fear is that I will have no insurance again to cover my pre-existing conditions, and that I won't be able to afford medication that helps keep my diabetes in check. If they take away my coverage, I won't stop having diabetes. And I also learned after all these years that I have a medical condition which prevented me from having children. I always wondered why, I was married, I never had children. So if I would have found out sooner, my life would have been a little bit different, but I'm a little too old for that now. So I work hard, and I'm a contributing member of society. If I had known about my health issues earlier, like I said, my life may have been different. But I have a better life now knowing about my medical conditions and being able to take care of them. My health was basically hanging on by a thread. If I'm not well, I won't be able to take care of my mother and the family I work for with children with developmental disabilities. Also, like I said, I'm a home care provider for the IHSS program, and I only make minimum wage. So the reason I didn't have health care before is because I couldn't afford it, and I wouldn't have been able to afford the medication either. Now with the Medi-Cal, I'm able to get the health care I need and get the medication. And also another thing about if they replace the ACA with the AHCA, am I saying that right? Then IHSS may be impacted as well. I also have a brother with mental illness. Mental health may be impacted as well. So it will impact my family in several different ways. So I would just urge Congress, just don't take away our health care. Leave it as it is. It's working good, right? Thank you.
Thank you again, Florence, and I concur. We should keep what's working and fix what's broken. That seems like a much smarter way for us to move forward. But next, we're going to have Ruben Chavez, Chief Administrative Officer for the Clinica Sierra Vista, present.
Good afternoon, Honorable Chairman Arambula, Chairman Wood, Assembly Member Santiago, and the rest of the panel. Thank you for being here today. My name is Ruben Chavez. I'm with Clinica Sierra Vista. I'm the Chief Administrative Officer for here in Fresno County. Clinica Sierra Vista is a nonprofit, federally qualified health center, and we've been in existence since 1971. Clinica's roots are in farm workers. We were a farm worker clinic in 1971 in Weed Patch, California, and today we have over 28 health centers in 3 different counties: Fresno County, Kern County, and Inyo County. Last year we served approximately 150,000 patients in those 3 counties, with about 500,000 patient visits. And we provide primary care, we provide dental care, we provide behavioral health services. We're kind of a one-stop shop here in Fresno, Kern County, and in Inyo County. Our mission and our passion, and one of the reasons why I'm with Clinica, is that we're here to serve the underserved, the underrepresented, and everyone else. It is our mission, it is our passion to make sure that we take care of that population, because that's who we are. That's who I am, that's who everyone else is, that's who we are. So, to put it in context, when we talk about Fresno County, last year we had about 48,000 patients that we have seen in Fresno County, with about 140,000 patient visits. So that's a lot of people we take care of. We have about 320 320 employees here in Fresno County, with about another 800, 900 down in Kern County. So we're a very large organization. So what I want to talk about briefly with you today was like, how is this going to affect agencies like Clinica? So before the ACA, Clinica took care of everyone. We took care of the patients. After the ACA and during the ACA, we will take care of patients. We will be here. We're not leaving no matter what. However, this will affect us financially. When you talk about Medi-Cal enrollment and you talk about patients that we've seen who will no longer have Medi-Cal through expanded Medi-Cal or even through Covered California, Before the ACA, we were about 45, 46, 47% Medi-Cal. After the ACA, we're about 66%. So you can see about a 20% increase in Medicaid, which is substantial for us. Fortunately, we have wonderful leadership who's been with us for a long time. Our CFO and our CEO have been with us for almost 80 years combined. And we've run a very tight ship. We're very fiscally conservative. So we do well, but it's going to hurt us. Okay, we can't put a dollar amount to it. We may lose employees. I know that we have certified enrollment counselors who help people enroll into Medicaid and to Covered California. Actually, we enrolled, as an organization, last year we enrolled 12,800 people into either Medicaid or Covered California. So that's a lot of people that we helped. Now, when these programs go away or expanded Medi-Cal goes away, Covered California, what happens to those staff? Okay, we hire doctors, we hire nurse practitioners, we hire front reception, back reception, we hire medical assistants, nurses. So this is our community. This is the community in Fresno County. These are the people that are going to lose their jobs if something happens or if this continues to get worse. But like I said, we're not going anywhere, and we are fiscally conservative, very strong. But there are other FQHCs in the area who may not be as strong. So what's going to happen to them? What's going to happen to the care that they provide? What's going to happen to those patients? Sure, there's $422 million going to be taken away from Planned Parenthood into FQHCs, but what happened to those patients that were at Planned Parenthood? They're going to come over to the FQHCs, or they're not going to have care at all. So don't get confused or mythed by the smoke and mirrors. Sure, maybe we'll get some more money, $422 million, but that's going to be spread out over the whole country. And remember, there's about 1,200, 1,300 FQHCs in the whole country that serve these communities. But the final thing I want to talk about is, as an organization, like I said, we will be here. We will always be here. It's going to hurt us financially, but we're going to keep going. I want to share a story of one of our patients that we have. She comes to us. She receives her medical care, her dental care, her behavioral health at Clinica. She relies on Medi-Cal as her source of health coverage. That's all she has. Okay? She has a DACA child, a Deferred Action for Childhood Arrivals, and she has a child who qualified under California's Senate Bill 75, full scope Medi-Cal for children. She has a child as well. So we have a lot of mixed families in our population. I think most FQHCs do. And she also has two other children who were born in the United States, but one of them is autistic. Okay? What is she going to do? What is she going to do when Medicaid is dismantled, when expanded Medicaid, when Covered California, when everything goes away? What is she going to do? Okay? So just remember that, and I know you're here today to help us continue the fight. And final, again, Clinica will be here, we will always be here, but it's going to be a lot tougher for us, it's going to be a lot harder for us. Financially, we're going to have to make some decisions just like the state. The state's going to be put in a hard place, between a rock and a hard place. So again, I want to thank you. I want to thank all the members for sharing your stories with us. And I also want to thank the Assembly members for being here. Thank you.
Thank you, Mr. Chavez. Next, we have Noe Paramo, who's he's the co-director of the CRLA Legal Assistance Foundation. Noe?
Chairs Wood, Arambala, Committee Member Santiago. Hello, my name is Noe Paramo. I represent California Rural Legal Assistance Foundation. CRLAF is a partner with the Fresno Building Healthy Communities Prevention Action Team. Many of the representatives are here today in the audience. I appreciate the opportunity to testify before you on perspectives, the impact the American Health Care Act will have on the safety net for farm workers in poor communities. ACA sounds close to a Spanish word called hacha, which means axe. That is exactly what the ACHA will have on our farm worker and poor communities in the San Joaquin Valley. An axe that will cut the amazing work done by the many to make health insurance a reality for hundreds of thousands of San Joaquin Valley residents who benefit from the Covered California and expanded Medi-Cal. Moreover, the ACA allowed the state of California to provide expanded Medi-Cal to all children under 19 years of age. Today we heard from the experts and the consumers the devastating economic and fiscal impacts ACA will have on the valley. I'm from a farm worker family raised in Tulare County. I experienced not having health insurance, no dental care, my parents borrowing money to pay for care. We in the San Joaquin Valley have come a long way from those dark days when there was little, if any, help. ACA is good health policy. ACA meaning the Affordable Care Act. The ACHA is bad health policy and will take us backwards. How is this bad policy and who will get the axe? First, ACHA will exacerbate the impact on farm workers in the rural communities who will see the Medi-Cal cuts. These cuts will impact the rural health centers, as you've heard. This will destabilize the health services in the rural areas. People will come into cities like Fresno and other cities in the valley for their health care, shifting a greater burden on the healthcare delivery system and return to overcrowded emergency rooms. ACA repeals the employer mandate. This will impact farm workers who may have health insurance provided by their ag employer. If there is no incentive to keep their health insurance plans, the ag industry will likely axe the coverage plans. Second, ACA will unjustly eliminate tax credits by changing the ACA eligibility and create additional barriers for medical enrollment. Moreover, as a provider of legal assistance, we hear from immigrants concerned about whether accessing health benefits like Medi-Cal will impact their status and their personal information will be accessed by DHS or ICE. These are legitimate fears, which means residents will go without care because of the chilling effect the new administration's executive orders are having on our immigrant communities. ACA will impact the legal services community. Legal services providers funded through the Legal Services Corporation provide legal assistance, fact sheets, and other materials around people's legal rights, healthcare rights. These providers will be a necessary safety net to residents as they navigate the changes brought on by this new proposal. However, legal services may not be in place to help provide these basic needs, these basic services that are needed because the 2018 administration's budget eliminates the Legal Services Corporation. We need to make sure our legal services safety net is intact. Finally, we should embrace our communities, the farm worker, the working poor, immigrants, our elderly and disabled, and our children, to better their lives for themselves, to build healthy communities. They were much better under the Affordable Care Act. That was a good policy. It is a good policy. ACHA is the axe and is bad policy. Our San Joaquin Valley residents and community deserves better. Thank you for your time and for hosting this key hearing today.
Thank you, sir. And for the audience, just to prepare you, we have two final presenters before public comment. So within the next 10 minutes, if you're willing and able, it's our turn to hear from you next. So next we have Mary Adair, who's here with us from the Legislative Affairs of the Behavioral Health Directors Association of California.
Yes, good afternoon. Mary Adair with the County Behavioral Health Directors Association of California. We represent public behavioral health systems throughout the state. Millions of Californians will lose access to important mental health and substance use disorder treatments under the American Health Care Act. If the Medi-Cal expansion is repealed, single, low-income, childless adults with serious mental illness will lose access to the health coverage that they just received under the Affordable Care Act. Under the American Health Care Act, county uncompensated costs will skyrocket, destabilizing our local healthcare systems. Important mental health and substance use disorder treatment services will cease to exist, and counties and health providers will be forced to lay off workers. The loss of the Medicaid expansion will also gut the state's substance use disorder system at a time when Californians are grappling with the opioid crisis and other addictions. Under California's drug Medi-Cal organized delivery system waiver, counties may opt into expanded substance use disorder benefits, but that whole waiver is at risk with the repeal of the Medicaid expansion. Taken as a whole, the American Health Care Act is a major retreat from the efforts to save people with the opioid epidemic. Mental health disorders sometimes fuel drug addiction, making both benefits essential to combating this crisis. It's for these reasons that we oppose the American Health Care Act. Thank you.
Thank you. Next, we have Kendra Rogers, Managing Director of Children Now.
Good. It's very good to be home. Good afternoon. Thank you, Chairman Arambula and Chairman Wood and Assemblymember Santiago. And I just want to thank the panel, and especially given that Children Now, we are a statewide nonpartisan children's policy and advocacy organization. And so I just really want to thank you, JC, for really literally bringing our work to life. Your voice was so beautifully and brilliantly displayed here in terms of the real impact. So my comments are just to add on to what JC already said. My remarks on the reasons why the American Health Care Act would be absolutely devastating for children are my focus here. While some members of Congress are trying to sell the bill as a replacement for the Affordable Care Act, instead, as many of my colleagues have pointed out here today, it's actually a fundamental restructuring of Medicaid that will significantly impact children the most. Medi-Cal is a necessary safety net for nearly 60% of California's kids. In the Central Valley, Medi-Cal is even more important. 2/3 of children, that's 775,000 kids. So just want to pause on that again. That's 775,000 children just here in the Central Valley are covered by Medi-Cal. I know how critical Medi-Cal is here in Fresno. I was born and raised here and served as the executive director of First Five Fresno County until 2014. I was with them since their early days in 2000 and saw that our very mission of making sure that children started school thriving and ready to learn rested on the back of whether or not those children had access to preventative health care beginning before birth. We know that the inequities that exist in our kids' educational outcomes begin before birth, and what we now know more than ever is the impact of toxic stress, which we know is more profound in communities of poverty, those most impacted by the cuts and the changes being proposed by the AHCA, would be absolutely devastating. We know that the impact of a child's brain development is most critical in the prenatal through age 3 time period. And we know that those children relying on Medi-Cal are most likely to suffer the devastating impacts that lack of access has. Research shows that children with health coverage miss fewer school days, they do better academically, they're more likely to graduate from high school and go on to college. They visit the emergency room less and are hospitalized less often. They also earn more money as adults. I want to bring that to life quickly, as I shared earlier. My son is currently not in school. He will be 16 in May, and he's not in school because he is currently receiving inpatient treatment for a recent bipolar diagnosis. He was diagnosed bipolar 1 after 2 5150 stays. Before that, my son was a straight A student. We knew he struggled with ADHD, but his mental health issues as he got older continued to exacerbate themselves. He then quickly plummeted into failing grades, substance abuse, and early involvement with the law. The only reason that my child is going to be back on track and walk across the graduation line is because I have health insurance. Because I work for Children Now, an employer who believes in what it preaches and invests in high-quality health insurance that gave my son access. I have an insurance company that continues to make sure that my son's mental health issues are addressed. So as we continue to have a community that lifts up all of the issues around education, we cannot undermine the fact that the health of our students is the reason that they are able to be successful educationally, and especially for our children with mental health issues. So you consider just here in Fresno Unified, where 80% of the children live in poverty, that means 80% of the children in Fresno Unified depend on Medi-Cal for their care. And when we think about the issues, the toxic stress, the mental health, the trauma that's impacted those kids, taking away their health care is taking away their opportunity for educational success. So again, I just want to state that we've really worked hard, as you've heard, over the last 2 decades to transform California from a state with 2 million uninsured kids to one in which almost every single child has access to affordable health coverage. And we've come too far to lose ground now. In December 2016, nearly 700 diverse organizations in California, businesses, organizations, associations, sent a letter to our state representatives in Congress reminding them that it is their responsibility to do what's right for kids, to be pro-kid. In the letter, organizations and businesses from across California called on state leaders to protect health coverage for children and families, and we want to commend this panel and this committee for doing that very thing today. The American Health Care Act is bad for kids, and what's bad for kids is even worse for California's future. Thank you very much.
First, thank you to all of our panelists, and we're going to go ahead and go to the point where we actually want to hear from you, more of you. We've been hearing from you, obviously, but so we're going to invite you to come to the microphone. Our only caveat is we literally, out of respect to the city of Fresno, we have to be out of here at 4:30, and I'd like to allow a few minutes for closing comments from our folks. But please feel free to come forward, and we'd love to hear from you.
Honorable Chair Woods and honorable members of the Assembly. My name is Paul H. Garcia. I am a senior citizen and 65 years old. I'm disabled and I'm receiving Medicare and Medi-Cal. And the thing is, I'm half blind and partially deaf and arthritis all over my body. But I still have the courage to come all the way down here from Merced County and Delhi, small community, but originally from Fresno, California, which is Calawa. But I really want to thank all the people that came out here, and I give them credit, especially the ones that are disabled, that had the time to come out here and voice their opinion. I don't want to take too much time, but I think that going out there and contacting our congressmen, our assembly people, our governor, and also other organizations, that let them know that this is unacceptable. Health care is important to the people out here, affordable health care. And I think that the people that are affected are the poor people out here that were barely making enough to pay as it is. So I encourage each and one of you out here to contact your elected officials and every organization that this is not acceptable. Thank you very much.
Thank you, sir.
Hi, my name is Jen McClelland, and I'm here with my 5-year-old disabled child. He is a medically fragile, technology-dependent child. He's bad at breathing. He's so bad at breathing that he depends on a ventilator to keep him alive at night. Every night when we tuck him into bed, we hook him up to a machine that breathes for him. Medicaid pays for that ventilator. We're a middle-class family. We have Blue Cross health insurance provided by our employers. Private health insurance never pays for the amount of care that seriously disabled children need to stay alive. My question is my son's life worth saving? This isn't a soundbite, this isn't a policy, this is an actual human life. And I just want to make sure, even though the GOP is making policies that say that my son's life isn't worth living in California, I think we all think it is. Thank you.
Ma'am, if I could, I just wanted a second to address your question, and the answer is obviously yes. You know, I have 3 young daughters myself, and I know how much we as parents care about our kids, and I'm impressed that you took the time to come and share your story. So thank you for your courage.
As am I.
Hello, my name is Karen Rouleau. My story is, our 2 children were born in 1993 and 95 with a pre-existing condition, congenital, severe to profound bilateral hearing loss. Both later met the criteria and therefore were candidates for cochlear implants. However, we own a small family-run business with no employees and do not have the privilege of participating in a group health care plan, and therefore we are individually insured. When our children were born, our medical plan would not cover them, and we could not find an insurer who would. We were desperate, so we called the California Insurance Commissioner for help. It was then that we learned about California's Major Risk Medical Insurance Program, otherwise known as Mr. MIP. This plan provided health insurance to Californians who were considered high risk because of pre-existing medical conditions. While we were relieved to finally have coverage for our children, we were financially burdened with exorbitantly expensive premiums. And with each passing year, the premiums soared until eventually our children were kicked off Mr. MIP, since there were so many Californians with pre-existing conditions just waiting for coverage and funding was limited. With this high-risk pool, California was running out of money quickly, and it was unsustainable. Our children did very well in the mainstream school system because of their cochlear implants, and are now very independent young adults who have both gone on to acquire college degrees. Without medical coverage, cochlear implants would have been unaffordable for us. Thank goodness for the passage of the Affordable Care Act in 2009. Our children were once again insured, and our premium was cut in half. They are 21 and 24 years of age now and are still on our policy. Their cochlear implants need to be upgraded every 5 to 7 years. The cost of new equipment is very high, and the cost of visiting the audiologist is very high, more than $900 a visit. Should the GOP healthcare bill be passed, our children would be put back into a high-risk pool, and from what I understand, this again will be very expensive. Once they turn 26 and can no longer be on our plan, I don't know how they will be able to afford it. My daughter has been graduated for a year now and has been looking for employment, so she doesn't even have a job aside from taking care of cats and Galileo summer camp, so she wouldn't be able to afford that. But not only will our children be affected by this GOP healthcare plan, but also low-income families with young hearing-impaired children will not have the opportunity to choose between deaf culture or hearing culture for their children, as cochlear implants will no longer be an option for them. Cochlear implants should not be available only to the privileged. Thank you.
Thank you. Thank you. I want to make a comment because you brought up a really, and first of all, thank you very much for coming, and thank you for your message. And the high risk pool that you spoke of that California had was about $750 million, and there was a huge waiting list for that. So the federal government, in their new not Affordable Care Act, is putting aside $100 billion for 10 years. So if, as 10% of the population of the United States, we were to get our proportional share, we might get $1 billion a year, which is nowhere near adequate to take care of people who have high risk. So once again, a real challenge for us. Please, come up.
I'm standing here on behalf of the homeless and the homeless veterans. I would like to defend the rights of this unseen community. On March 23, 2010, the Affordable Health Care Act was a light in the dark times of this often neglected community. Now I'm going to share you two stories because I'm volunteering my time to help them. These stories are about two homeless who have benefited tremendously from the Obamacare. The two homeless were receiving medications, and gradually they could find jobs as time passed by. One purchased a used car and lived in his car and applied for a housing and eventually started his new life by finally having a home and health care needed, and at the end he used his new job's health care plan instead of the ACA. This means that this individual temporarily used the ACA. The second former homeless received help with the medications, left the streets, and found a job as a caregiver and was able to live in a small home. This individual has just finished one semester of college toward her goal of becoming a social worker. So these were two sample stories of the reality of the Affordable Care Act. ACA gives the freedom to live again. It gives a chance for every mental health patient who is unable to work to get the needed therapy and support. It gives them a second chance to live and become productive both for themselves and their community. Repealing and replacing the Affordable Care Act is unacceptable and dangerous for our people. It will make the poor poorer. Please protect the Patient Protection Affordable Care Act, known as Obamacare, because it already works. To sum up, I would like to tell you the definition of healthcare. The definition of healthcare is the maintenance or improvement of health via the diagnosis, treatment, and prevention of disease, illness, injury, and other physical and mental impairments in human beings. Based on this definition, a healthcare without a mental health insurance is not a healthcare.
Hi, my name is Cassie Kiefer. Thank you for holding this event. I'm here today because I'm worried about the proposed loss of the Affordable Care Act and the implementation of the American Health Care Act. Both my husband and I are self-employed. I work as a marketing consultant, and he works as a software developer for an early stage tech startup. Neither one of us qualify for employer-sponsored health insurance. We were both able to quit our day jobs and pursue our entrepreneurial dreams because we were able to purchase high-quality, affordable health insurance through our state's ACA exchange-covered California. If we lose our health insurance, one or both of us will have to quit our jobs, businesses we've worked to build over the last 5 years. Trump Care will inhibit the launch of small businesses and destroy innovation here in California. But this inconvenience for us pales in comparison to what my mom will face if she loses her Medicaid. My mom is 60 years old. She's been seeking full-time work for the last few years after she was laid off from her job at a retail distribution center. She has several serious health concerns. She suffers constant debilitating pain in both of her knees from arthritis. She has diabetes, high blood pressure, and early-stage macular degeneration that makes it hard for her to see and impossible to drive past dark. Despite this constant pain, she works as a part-time home care worker, providing in-home assistance to other seniors who are slightly worse off than she is. She's barely making enough money to survive and certainly isn't eligible for employer-sponsored health insurance. The only reason my mom has health insurance right now is because she was eligible for coverage under the Affordable Care Act's Medicaid expansion for older adults. I'm concerned that if my mom loses her health insurance, we will not be able to afford the high premiums and cost of the prescription medications that she needs to survive. I know my mom is not alone. She's living the same story that many of our moms and grandmas and neighbors here in California are living. Too young to qualify for Medicare, but unable to insure the health insurance that they need. A large number of the newly uninsured under Trump Care will be vulnerable people like my mom, between the ages of 50 and 64, who will not be able to afford the much higher individual market premiums in this bill. Please do whatever you can to stop this bill and protect my family's health coverage. Thank you.
Thank you.
My name is Judy Hess. I'm with Progressive Democrats of America and the Healthy California Campaign. So, honorable chairs, members, and friends, I hear your stories, and they're heart-wrenching, and they really tug at me. I want to respond directly to Natasha Moiseev, who asked that if this new law is enacted, to please put a program in place to fill the gap. Certainly, we cannot have this new law enacted, but should the unthinkable happen, we do have something. It's something better. It's something even better than the Affordable Care Act. And the wonderful news is, this is a message of hope. We found the money, okay? Senator Ricardo Lara has introduced SB 562, so please write that number down and look it up. And a fiscal study is en route, so it is in process. You will have it. The essentials of this are, it's a single-payer health care program. We save incredible amounts of money because we save 27% of every $100 that are put, $27 out of every 100 put into health insurance premiums. And so that's where the money gets saved. It's the essential elements are everybody in, nobody out. Nobody out. No deductibles, no copays, comprehensive care across the board, and you choose your own doctor and your health care providers. So if you have questions about this bill, please see me outside. I have information, and I wanted to bring you this message of hope.
Hello, my name is Christine Springer. I'm a resident here in Fresno, and I would like to disabuse any of you out there who think that loss of Medicaid are problems that are, you know, something to just think of as a possibility. We are living with the reality of the loss of Medicaid due to a paperwork problem. Today, the city came to turn off the water. My nephew was paralyzed. He's a high-functioning quad, meaning he's got partial use of his arms, but he's a full paraplegic. He has no mobility, but all of the pain. Without Medicaid, he is forced to cover all of his uncovered Medicaid, Social Security disability that isn't covered by that. So his power chair arms and hand controls are literally being held on with duct tape because he can't repair his chair. He can't get the back that he needs to sit upright, and his spine is twisting because he can't sit up. He's covering his medical supplies that he needs because he has no control of his bladder. So he has to have urinary catheters. Medicaid paid for his home care, which my sister, his mother, was providing at a reduced rate of pay simply because they share the same household, so she can be available to him 24/7. Today, the city came to turn off the water because without the income provided by her in-home care, half the operating budget of the household is gone. We had to borrow money to keep the car from being repossessed. The power will be turned off at the end of the month. So if you're wondering what the reality of losing Medicaid coverage is to households that depend on it, this is the reality. They will be homeless. We had to borrow money to keep the car from being repossessed because that is his lifeline. We have nothing else. Nothing. Taking money out to buy his, just the copay for one of his prescriptions is over $82. The income for Social Security disability is not extravagant. But when you take just the copay for one prescription, that comes out of his food budget. He hasn't had fresh vegetables in months, simply because the paperwork for his reauthorization for Medicaid to pay for what disability doesn't cover and paid for his mother to care for him in his home was cut off in the middle of October. October, we have been struggling this long, ever since, just to try to get the paperwork straightened out so she can get her back pay so we can pay off all the bills that are piling up, like all the utilities, they have no phone. We can't even cut down the AT&T, combined TV, internet, because the internet is his lifeline to communicate, because they can't even use the cell phone without the in-home internet to keep it connected, or to try to stay in communication to try to get some help. Okay, so don't think that this is just some nebulous future. This is happening today. Today. The city came out to turn the water off today. The minimum payment that they were going to accept was $200 of the past due. Everything is piling up past due because there is half the household income is gone. They said, well, okay, well, if you can come up with $150 some odd by the 4th, we'll leave it on for now. And we're going, I can play dominoes better than you can. But help me, please. Thank you. So that this reality doesn't become any of yours. Don't let their reality become yours. Please. The ACA might not be all that great, but it's a whole lot better than what it was. And I'm actively working to I spent over 40 years in healthcare. Over 40 years. Believe me, I know for a fact that for-profit health insurance is a racket. It is a purely parasitic industry that adds nothing to healthcare. All it does is extract it like oil out of the ground. It adds nothing to healthcare. All it does is take resources away from you and your doctor and your hospitals and your clinics. That's all it does. All it does is support itself. Single payer. Everybody contributes to one payment center according to your income, and everyone has universal access without the insurance companies taking their cut first. Don't let our reality become yours. Please help us.
I would like to say hello and thank you for doing what you do. My name is Regina Cox. I've worked in the healthcare field for over 27 years. Currently, as a communicable disease specialist, I work as a college professor at Fresno Pacific University and State Community College University. I have a passion for healthcare. I'm finishing my PhD in healthcare, but I stand today to advocate for the consumers, advocate for my parents, and advocate for college students. I'm reminded of when my son went to college, I had to make a choice. Do I pay for tuition and fees because I don't qualify for financial aid, or do I get an insurance policy? But ACA came along, and it enabled me to keep him onto the health care insurance until he was 26 years old. My father passed away waiting to see a specialist, and this was prior to the ACA. And one of the things about the ACA also that was helpful, when my mother had her knee replacements, I was able to come to work and have confidence that she was going to be provided for by having physical therapy to go into the house, by having people to go into the house to draw the lab work, and having a home health nurse. All of that is important, not only just for the ones that's sick, but also for the ones that's trying to provide services. I work now providing services to the underserved. I do education and prevention. If this ACA is not, if it's done away with, if it's repealed, what's going to happen is going to be a domino effect. What's going to happen is that access to health care is going to be attacked. It's going to limit the amount of providers. There was thousands of staff members that was hired to implement this ACA. They're going to lose their jobs. And when they lose their jobs, they're not going to have benefits. They're not going to have resources. So you're going to see the unemployment rate's going to increase. You're going to see the emergency rooms that's going to be flooded for simple things like a toe ache or stomach ache. And healthcare expenditure is already done exceeded what it should have exceeded. And also, preventative health care, people are not going to do the preventative health care, and then you're going to see an increase in diseases. And that's going to increase the cost. So my ask for you today is let's stand together, let's unite, and let's fight and address this issue. Thank you.
Buenas tardes, mi nombre es Alondra Quintero. Gracias por la invitación. Mi esposo está deshabilitado. Él estuvo conectado a una máquina de diálisis por 9 años. Entonces, él es sobreviviente de trasplante de riñón ahora. Gracias a este programa de ACA, él tiene sus medicamentos. Si no tuviera él sus medicamentos, él ya hubiera fallecido. Son medicamentos que no hay manera de pagarlos, son bastante costosos y es medicamento que le quedó de por vida. Pero gracias a este programa, él puede tener sus medicamentos. Si ACA fuera revocada, él no tendría manera de tener sus medicamentos, él no puede trabajar porque es una persona deshabilitada de por vida.
Hello, good afternoon. My name is Alondra Quintero. For 9 years, my husband was connected to the machine due to issue with his kidneys. Today, he has a kidney transplant survival, and thanks to ACA, he relieves his condition regular without any problem. But I don't know what happened to him and to our family if the ACA is repealed. He can work, so he can throw my job. It's take care of him. So if we don't have the ACA, I don't know how can survive my family.
Gracias.
Buenas tardes, mi nombre es Silvia Carrillo y estoy aquí para luchar contra la revocación de ACA. Si no fuera por Medical, yo no estaría aquí. Hoy por años viví con dolores fuertes en el estómago que constantemente me llevaban a ir a la sala de emergencias. Yo no tenía aseguranza médica y no podía pagar para que me hicieran estudios, así que seguí viviendo con esos dolores. Pero todo cambió hace 3 años cuando fui elegible para Medical. Tuve una serie de estudios y los doctores encontraron que estaba en etapa avanzada de hepatitis C y que había desarrollado ya cirrosis, una condición que permanece crónica si no hay tratamiento, pero el cual Medical me otorgó, aprobó el tratamiento y yo no hubiera vivido por más de unos cuantos años, más gracias a Medical, a Dios, en este año ya no tengo hepatitis ni cirrosis. Si revocaran acá, gente como yo que tenemos Medical morirían. Hay mucha gente que depende de Medical. De hecho, mi suegro necesita medicamentos para su diabetes, el cual él tiene diálisis. Mi nieto que necesita ver un psicólogo depende de Medical. Ellos también sufrirían si aprueban la revocación. Les pido que no revoquen el ACA. A mucha gente le causaría mucho dolor. Gracias por su tiempo.
Hi, my name is Silvia Carrillo, and I'm here to fight to not repeat the ACA. If it weren't for Medical, we are not standing here today. For years, I lived with constant stomach pain that often forced me to go to the ER. I didn't have healthcare insurance, and I couldn't afford to get tested, so I kept it on life with this pain. But everything changed for me 3 years ago when I'm able to get Medical. I went through to a series of tests, and the doctors found I had very advanced stage of hepatitis C, so advanced and had developed into cirrhosis, which remains a chronic condition. If left on treatment, I'm not in Medical, may I not survive it too much longer. Thanks to Medical, since January, I no longer have the illness. If the AC is repealed, people like me who have Medical will die. There is so many other people who rely on Medical. In fact, my father-in-law who need dialysis and my grandson who need to see a therapist, both really on Medical, they will also suffer to the repeal pass. I urge to you to stop the repeal of the ACA. It will cause so many people so much pain. Thank you for your time.
Hi, thank you all of you for being here, for giving us this chance of giving you our own stories. My name is Valesca Sanchez. I work for Fresno Unified School District. I'm not here because of me. I'm here because of my family. Is it really hard to see your family suffer? I'm a medium class, but my family is not. They are farmers, mechanic, and the majority of them are immigrant. So a lot of your people, more than 50% of your people in the United States are immigrants. And this is how we survive. Not only us, it's everybody. It doesn't matter the race or the color, it affects all of us. And I think this is very wrong what they're doing, because you state that you care for your future is him right there. And if you remove him, that help, you're just ruining your own United States. I'm just asking for help, and that's all I could say.
Hello, everybody. Thank you for being here today and giving me this opportunity to share my story. Actually, it's not my story. It's like I'm not here for myself. I'm here for just to say how important that the Medi-Cal is to our families. My niece, who was 15, who goes to Hoover High, was came out with these lumps underneath her armpit and on her body. And I told my sister, I said, you need to take her to the hospital quickly, because that looks like it could be a staph infection. And sure enough, it was staph infection, and she was able to get, a prescription for that. And if my sister didn't have Medi-Cal for her daughter, she wouldn't be alive today, because staph infection is very, very serious. And all it took was a prescription to save her life. And Medi-Cal did that for them. So I want to thank you for hearing my story. Thank you.
Thank you.
Good afternoon. Thank you, Chairman Arambula and Chairman Wood, for this opportunity. My name is Justina Felix, and I am the Fresno Advocacy Manager for the American Lung Association in California. I'm here today to voice our concern about the American Health Care Act and its impact on those suffering from lung disease such as asthma, COPD, and lung cancer. The Health Care Act will lead to greater incidence of lung disease by eliminating the Prevention and Public Health Fund and repealing the preventative services covered in the Medi-Cal expansion. These are key programs and protections that ensure that people have access to preventative services like quit smoking programs. Prevention must remain at the heart of any proposal aimed at improving the health of all Americans. The Lung Association opposes significant cost shifting to states and per capita Medicaid caps. Both are likely to lead to a decrease in quality and affordable coverage for those suffering from lung disease. Any healthcare law should ensure that people have access to affordable, adequate coverage. This coverage should include reasonable premiums, cost sharing, and out-of-pocket limits with adequate financial assistance to lower-income individuals. Any changes to current law should maintain an emphasis on preventing disease, as well as preserve coverage for Americans who currently have health care and extend coverage to those who remain uninsured, and lower costs and improve quality for all. Our mission is to fight to prevent lung disease. It's to reduce the incidence and exacerbations of lung disease, improve diagnosis and treatments for those living with lung disease, and increase patient access to appropriate health care. I'm also here as a parent. I am a mother to an 8-year-old who is in her 3rd year of remission of leukemia. And like Ms. Natasha was saying earlier, that, she was lucky because she had support. And I was lucky because my daughter had 2 working parents that we were able to manage to get through her treatments and pay and ensure that she would be healthy. But not very many families would be that lucky with this change. We urge you to vote no on the American Health Care Act when it comes to the floor this week, and instead work with all stakeholders, especially patient organizations, to craft legislation that meets the needs of all Americans. Thank you.
Hello, my name is Dr. Luz Corona Gomez. I'm here as a concerned citizen. I was born and raised in Selma. I am here as a public health worker. I have a master's in public health. I'm here as a physician. I'm doing my training in obstetrics and gynecology currently. I'm fortunate to be able to provide care to women and girls, which has been my dream for a long time because I know how it is not to have health insurance. My parents are farm workers. They came here from Mexico for a better life for my sisters and I, and they worked every day of their life. My parents could not afford appropriate living for us, so we had to work as farm workers. As a child, I spent my summers picking grapes, yet my parents could not afford health insurance for us. I don't understand how a family who is all working, who their children are working, yet cannot have health insurance. This was before the ACA. My sisters and I finally were able to get health insurance through S-CHIP, Healthy Families. Unfortunately, my parents could not get health insurance. Thanks to the ACA, my parents now have health insurance, and thanks to the ACA, my patients have health insurance. If the ACA was to be put away and this new Trump Care was to put in place, my parents would not have health insurance, my patients would not have health insurance. As an individual who has not had health insurance and now has the privilege to have health insurance and care for patients, I beg you, please do not take this away from us, not only from the patients, but as a provider. I cannot imagine having to turn my patients away and tell them, I cannot take care of you because you do not have health insurance. Please don't do this to us.
Just wanted to add one comment, if I could, to the doctor who just spoke. I practiced medicine in Selma for a decade as well, and know how important it is in our rural communities that we have physicians and providers who are from our communities and understand the struggles of their patients, and it's really inspiring to see that in you right now. So thank you for your testimony.
Muy buenas tardes a todos. Yo voy a hablar en español porque no hablo muy bien el inglés. Voy a dar primero, déjenme darle las gracias a este estado maravilloso de California, el que me ha dado y me ha ayudado en mi salud. Yo soy persona deshabilitada, nací con deshabilidad de epilepsia, pero aquí estoy, gracias a Dios y este maravilloso país que me ha ayudado. Mi nombre es Blanca Lozano, vengo del condado de Merced, soy líder del pueblo de Delhi y pertenezco a Merced Advisor County, MAC. Sabemos todos que somos seres humanos y la salud es el principal elemento que se requiere para vivir. A través de los años, la gente de mayor edad se enferma y empieza a tener cambios de salud, al igual que los niños y los jóvenes que se encuentran con alguna discapacidad de salud y necesitan la ayuda del seguro médico, que es el Medical o el Medicare. Lamento y siento mucho que nuestro presidente elegido, Donald Trump, esté tomando direcciones tan drásticas que él quiere quitar el Medical, sabiendo que la gente pobre necesita el Medical y los que trabajan en el campo, que son los que más desgastan sus fuerzas, y tenemos comida en nuestras mesas por sus duros trabajos que ellos desempeñan para todos nosotros. Unidos todos hay que pensar lo mejor y una idea cómo solucionar que no nos falte un seguro médico. El pueblo de California, desea que todos tengamos un seguro médico, ya que hemos oído tantos testimonios de que es necesario. Hay que dar tiempo al tiempo, pero principalmente pensando que todos los que trabajan se les quita una porción de su cheque, que en una emergencia de enfermedad tenemos dinero para respaldarnos con un seguro médico y lo merecemos porque ya trabajamos por nuestro seguro de salud. Gracias a todos ustedes que me escucharon.
Thank you.
Muy buenas tardes, señor Wood, asambleísta. Ya sé que usted sabe el español, ¿verdad?
I'm just going to nod because
Okay.
my Spanish isn't very
I'm
good.
kidding.
So whatever you're saying
Hey,
is great.
welcome to Fresno.
Thank you.
And where did everyone go? Oh, we're still here. Okay. So here we go. I know I'm really hungry right now, but anyhow, I just want to, I'm here as an advocate for women's health. As you can see,
Hey.
Planned Parenthood. Thank you. Thank you. So what I'm here to share is, and with folks in the audience, because many don't know, is, and with all due respect to Mr. Chavez from Clinica Sierra Vista, we are one of the strongest healthcare providers in California. And with the Affordable Care Act, or the repealing of the Affordable Care Act, this defunding Planned Parenthood has been in front of the news, and it's been everywhere when it comes to what the congressional members want to do. And part of that, obviously, that is to defund Planned Parenthood. I'm just going to let folks know that the term defunding Planned Parenthood is a misnomer, okay? There is no blank check that Planned Parenthood gets from the federal government, and it's not in the budget. Instead, the legislation prevents millions of women who rely on Medicaid from accessing healthcare providers they've been depending on for decades. This policy also has nothing to do with abortion, nothing. It instead cuts women off from cancer screenings, birth control, and HIV and STI testing and treatment. So I wanted to make sure that we all knew this, because that's what the other side is arguing, that the patients that come to Planned Parenthood are going to be able to, the FQHCs will be able to absorb that. And that's not true. We understand that our patients come to us for a reason, because we are a specialty provider when it comes to women's health. And not only women's health, but we also provide education and outreach services to men and women. We also offer transgender services. So we're out in the community providing everything we can, and yes, of course, it's important to work with other FQHCs. That's our job. But also our job is also to recognize that if there's other providers in the community that can do a better job, then let's work together. And my goal and what I've done is invited Congressman Valadao and Congressman Denham, Jeff Denham, to come over and visit our health centers, to really see what we do, to really put a face to the patients that we serve. Because many of them are at below the federal poverty level. Many of them. As we know, that's the way the valley is, but you know what? It's time for us to change that and be able to provide those services, because as I told Assemblymember Arambula when he was running, he came and spoke to us at a luncheon. I said, if somebody is feeling itchy, scratchy, or not feeling comfortable at all because of their health, they're not going to be able to perform at 100% at the level that they're supposed to. Why? Because of their health. Not only that, but Planned Parenthood also provides primary health care services. Many people don't know that. Many people want to bring it back to abortion services. Well, this funding that's being taken away is only used for preventive health care services, i.e. contraception, i.e. emergency contraception, also known as the oops, I did it again pill for some, okay? The thing is that those services are out there. Barrier methods, okay, condoms. There's all those preventive methods, women's well-women visits that we offer. So I want to let everyone know here, and even folks that are hearing us out there, to let your congressman know they're open to come for a visit. Come and visit our health centers. Come and visit the services and educational programs we provide. One more thing, we provide a program for young moms. Okay, we offer services to them, a 50-week program. And I want to say, and I want to thank you, Assemblymember Arambula, for coming on a tour of our health center and providing your input and letting us give you some information and sharing information with you about the work that we do. Thank you.
Thank you. I want to thank you for your advocacy. Honestly, I couldn't find my pink tie today. I usually wear a pink tie to these. Honestly, in support of Planned Parenthood. Planned Parenthood provides healthcare services to 855,000 people in California.
You're taking my talking points there.
I'm sorry. 855,000. And so when I took my tour of my Planned Parenthood affiliate and saw firsthand what they were doing, my eyes were wide open. This is often primary care for women, and it's also primary care for men. Right. And that's why it's so important that you're here today. So I really appreciate that you're here, the message, and I really hope that those two members of Congress take the time to come and see what you're actually doing, because this action, I believe, is punitive, it's petty, and it's wrong. And I'm so happy to see that in the State of the State address, when the governor talked about this, he talked about protecting health care in California, but he called out Planned Parenthood in specific. So we are going to do everything we can to protect and fund Planned Parenthood, because it is absolutely the right thing to do. Thank you very much.
Thank you.
Hello, good afternoon. I'm Dr. Catherine Catania, the Deputy Superintendent at Fresno County Superintendent of Schools Office, and Lupe Jaime, who's our Director of Early Child Education. Superintendent Jovino was here earlier, but he had to leave for another meeting. But he just wanted to pose one question. In Fresno County, we have approximately 200,000 students, and about 70% of those are students of poverty. So knowing that we have to have healthy students in the chairs to learn, his question is, if this Health Care Act were to be repealed and the other Health Care Act were to be enacted, then who's going to cover the health care of the children so that we can have 0 to 22 healthy kids in schools to be able to learn? In Fresno, over the past few years, we've done an excellent job of raising the educational level, raising graduation rates. A lot of those are because there were healthy kids in the seats. So we would just pose to the community and the state and federal government who's going to cover the kids so that they're healthy when they're in their seats.
Thank you. Thank you for the question. I just wanted to take a moment, if I could, to thank both Jim Jovino as well as what Fresno Unified is doing to start providing clinics within our schools. By your leadership, you're allowing kids to miss fewer days, and it's imperative that we do everything we can to get our kids every chance at success. So thank you guys for the leadership and work you're doing.
Good afternoon. My name is Emily Cameron. I'm an activist in the community. I just want to say thank you for this event, although I will say that all the sentiments expressed here today will be meaningless if our elected officials in the state legislature vote against single-payer SB 562. The Californians for a Healthy California Act is a wonderful act that includes everyone, including non-citizens. I don't think a lot of people know that. So you can just be a resident of California and you will be guaranteed health care, because germs don't know what your immigration status is. If somebody coughs on me and I get the flu and they're undocumented, then I'm out of luck, even though I'm a paying citizen. And I really appreciate this event, but, no offense, but none of you guys are in Congress. So what you can do, what some really great proactive direct action would be, is to vote yes on SB 562. And I will say, in 2012, we did have another single-payer bill in the state legislature, and 6 Democrats did not vote to support it. And it failed by 2 votes. We could have had single payer years ago. We would have avoided this mess, but Democrats killed single payer. So to every Democratic member of the California State Legislature, I just want to remind you that Obamacare is not the only thing that can be replaced.
Chairs, members, panelists, everyone. Thank you for having this hearing. Obviously, a very important topic. I'm Jim Kratzer. I'm a general pediatrician. I've been in practice in Fresno since 1979. I know that is a long time to some of you. I am a longtime member of the California Physicians Alliance. CAPA is a statewide organization of physicians and supporters founded in 1987 to work for improved health care for all in California and ultimately single payer. Obviously, we still have a lot of work to do. I may share just a little bit personally here. I grew up in Davis. I bounced around California for my education and training, Stanford, San Diego, San Francisco, Berkeley, before I was recruited to Fresno by the UCSF Fresno program to be on the faculty in pediatrics and family practice. I was, for the first 10 years here, full-time faculty in part-time practice. Since then, I have been part-time faculty in full-time practice. I rescheduled my patients this afternoon, believing that this was an important meeting. I have had the opportunity to have lived in a variety of countries, 1 year each in England, Australia, Germany, and Ghana. The first three of those have comprehensive universal health care for everyone. The last one, Ghana, has a program that looks pretty much like the US. A few rich people get very good care. There's not much left over for everybody else. I've also had the opportunity to spend shorter periods of time in Mexico and Nicaragua with enlightening experiences. I want to express my thanks and appreciation to everyone here, everyone working towards the same goals, and I want to pledge CAPA's assistance as an ally in this struggle. CAPA believes that the acceptable number of California residents without coverage is 0, and that goal is best achieved by single payer. Everybody in, nobody out. One high standard of care for everyone. To me personally, it was a shock to hear that the President of the United States had not known that healthcare in the US is complicated. As we know from experiences around the world, it doesn't need to be complicated. In fact, it's better when it's simple. Single payer is simple. Earlier presenters have noted the complex network of programs. As a network, the system in this country has lots of holes through which real people fall. Complexity introduces major costs and inefficiencies. Reducing those costs and inefficiencies results in savings that make single payer financially favorable for the state and this country. It's obvious to me that single payer is inevitable. If this country is to survive economically, we will eventually get there. As Winston Churchill is quoted, you can always count on America to do the right thing after it has tried everything else. So it is inevitable, but it is incumbent on us to address the question of how many people must suffer before we get there. While nationally there are advocates of single payer who are adamantly national single payer or nothing, they support H.R. 676 in Congress. We support H.R. 676 in Congress, but we also recognize that there is more work to do than just that. So CAPA has a three-pronged mission, has always had a three-pronged mission, to work at preventing us from going backwards. So we need to stop the AHCA. It is a very dangerous and damaging proposal. Second prong is to work supporting advances, especially as they may lead ultimately and incrementally to single payer. And then thirdly is to get to the promised land of single payer. We offer our assistance to like-minded people, of allies in this good work. We are in a time of crisis in this country. Yes, we need to work to keep things from getting worse. Yes, we need to work to make things better. And yes, we need to work towards single payer. Sí se puede.
If I may, before our next presenter, I wanted to let the public be aware that Chairman Wood and myself are co-chairing a select committee on universal health coverage for the state of California. So we will be starting to ask some of the very questions which have been posed to us so we can gain information and insights into feasibility and long-term viability. So we're starting to process it, ask those tough questions, and would like to involve you guys in that said process. If you guys have ways to help us make better, I oftentimes think us as public servants need that reminders that we work for you and that we need to be listening to the public and hearing from them about how best to move forward.
I'd just like to add, you know, I personally believe that health care is a right and not a privilege. And as we work towards the goal of universal coverage for everyone, one of the challenges that we face in this is that there will be financial pressures, and I have focused this year on doing everything I can to save as much money as we can from the Affordable Care Act, because we cannot afford to lose those resources. We cannot afford to start this venture $24 billion in the hole. And so right now in the Assembly, that is my sole focus, is trying to save as much as we can to give us the opportunity to build a better future. And so as SB 562 is debated and crafted in the Senate, and by the way, I do have the flyer that was handed out, and the bill as it exists today is 2 pages, okay? This is a lot more information that if this is truly in the bill, we haven't seen this yet. And that will be debated in the Senate. And so I look forward to that, and I encourage my colleague, Senator Lara and Senator Atkins, and moving forward with that. And that, as that progresses, that will come to my committee in the Assembly, and we will continue to work on that. But it will be challenging, but we cannot afford to do this without some of the federal money that we currently get. And so we're focusing on trying to save as much of that as we possibly can. So just so you get our perspective, and and that's why Dr. Arambula and I are working closely on this. It is, there may be hybrid approaches and things. There may be other things out there that we could incorporate in our vision for California that we may not have thought about yet. And so we want to engage as many people as possible going forward. It will be a long journey. one way or the other, it will be a long journey. But we need your help. So thank you. Thank you. Thank you. Appreciate that. So I just want to let people know only have a few more here, and I don't want to cut anybody off or anything. I've actually been told we have to clean up after ourselves as well. So if we could kind of wrap up our questions and comments in the next 10 minutes, that would be great. So I apologize. I don't want to cut anybody off, and I know you've waited a long time, so please.
My name is Kelly Everhart. I'm a Fresno County home care worker. I take care of my husband, who is a veteran, disabled veteran. He has lupus, chronic heart condition, and also a double amputee from the knees down. Also, my mother is 79 years old. She has Medi-Cal and Medicaid, because Medicaid does not pay for everything Medi-Cal picks up for. And I just want to ask you guys to please do what you can to help save the program, because they're both on home care, need home care workers, and half of our home care workers are on Medi-Cal. And without our being healthy ourselves, we're not going to be able to take care of our clients. So I just wanted to ask you personally to help to do what you can. ACA is not perfect, but the new program is not going to benefit anybody. So I just like to ask you, for my mother and my husband's sake, to please do what you can to help us.
Thank you.
Good afternoon. I'm Dr. Joseph Ruda, internist ophthalmologist. I have practiced in all 3 countries of North America. I've practiced for the last 47 years. Since government has entered medicine in this country, it has become more burdensome in order to take care of patients and to comply. Coding, billing, and authorizations to see a patient in the office has made it much more expensive, costly, inefficient, and unable to give the care. If I am referred a patient with diabetic retinopathy, fixing to go blind, I have to wait 3 days to get authorization to see the patient, or see them immediately and do it for free. I do a lot of free care. So I believe government, you folks, the public, federal government, and everyone in California and across the nation are people with their hearts in the right place, wanting medical care. But we can't, if we're going to work together, we can't make the system less efficient, less appropriate, less caring. You're putting me out of business. I can't afford the employees, the computer hardware, the software. And when I see a patient with one of these problems, I get paid from Medi-Cal $17. If I go close my office and go work in the clinic, some clinics will pay me $88 to see the same patient. But I can't give the same care that I can give in my office, because I don't have access to the specialty equipment that I have personally invested in. So I ask you folks in government who have control, doctors are only out here to get kicked around like an old football. Because anything that goes wrong with it, cost of medicines, inability to get access to care, waiting times, we're the bad guys. But we can't control it. But for God's sake, there's only 4 codes that we need to have in medicine. We have a healthy surgical patient or a sick surgical patient. We have a healthy medical patient or a sick medical patient. That's it. The government and our medical organization said, well, we need all these codes in order to comply with international standards, and we're going to do research on. That is the biggest pile of buffalo manure that is ever, and if they think that this physician believes it. The only reason for that coding is, and I'm sorry to take the time, is for the insurance company or federal government to evaluate it and say, you coded it wrong, you used the wrong modifier, we denied a payment. So it comes back to me, we recode it with the same codes, send it back in, and after 2 or 3 more months, they finally pay us. Also, medicine is the only section of the economy where we give a service, charge a fee, and the person receiving the fee or their insurance tells us how much they're going to pay us, what the usual and adjusted fee is, and we pay 20% less than that, and let's see you try to run your private practice on that. So these are the, we talking about correct amount of payment for a waitress in a restaurant, whether we should give her tip or not give a tip. Or you should try to do this in medicine. After you've spent already 15 years of your life living on just enough to be able to keep you alive and housed, then you get to this type of payment system. So speaking for the profession, there are these incongruities. If you're really interested in providing efficient, cost-effective, direct care, why are you pushing us out of business when the mom and pop scenario was the people who were more dedicated in giving the care most efficiently, that it cost me my first marriage because my wife says, you couldn't be going down to the office that frequently to see patients. So just because you're a damn workaholic, that's not a reason to kick us around as that proverbial football. And I'd like to see somebody, when I gave this same speech at the American Academy of Ophthalmology in Chicago last year and spoke to our representatives who were in the coding and billing and justifying this to us, the people behind the podium wanted to shut they thought I was a Chicago alderman. They wanted to shut off my microphone. But the people in the audience, 2/3 of them stood up and applauded what I was saying because they were, as ophthalmologists in the country, facing the same problems I'm talking about. You've heard enough this afternoon. Thank you.
Hi, how are you guys? My name is America Hernandez, and thank you for having this very important meeting. I just am here on behalf of DACA recipients. I myself am a DACA recipient, and also because I work for Kids in Need of Defense, unaccompanied minors. We all heavily rely on the ACA because before that we didn't have access to health care. And I relied on Planned Parenthood for my health care through college, and then after that, because I couldn't go anywhere else where they would take care of me without sending me huge bills that I couldn't afford. So I just want to thank you guys and ask that you do what you can to keep ACA or a better replacement in place and take care of everybody, including us immigrant children. Thank you.
Thank you.
Hello everyone, my name is Ilse Gallardo. First I want to start by sharing a quick personal story. In 2015, my mother was diagnosed with stage 4 breast cancer. Prior to that, she had never got any medical help. She couldn't qualify for Medi-Cal, but thankfully through the ACA, she was able to get into health insurance and been in treatment. So thankfully, her chemo therapy has been going so good, but or just worry is just what's gonna happen once if the ACA gets repealed. Even though myself, my husband, and my sisters and brother, we all work full-time, we don't think we could afford a $10,000 chemo treatment every week. So that's just really our concern, to see what's going to happen. The ACA shouldn't be repealed. I'm also here on behalf as a community advocate. I work for Central La Familia Advocacy Service, where we do a lot of our health enrollments through our health and wellness department. I had the pleasure to personally enroll hundreds of families and children into health insurance once the ACA came into place, especially our families in the rural area. through the work the center has provided through the communities, we're able to go to these communities and educate their families and enroll them on the spot for services, and also ensure that they're seeking the services. So a lot of our families are also worried on, now have their health insurance, I've been able to use it, but now what's going to happen with my medications, with my follow-up treatment. So I would all just plead our president not to repeal the ACA. Thank you.
Yeah. Thank you very much. And I apologize, but please, if we could keep it brief. We really do have to wrap this up in the next 7 minutes,
Sure.
so thank you.
Thank you so much for this moment. Just to share a word with you. My name is Nu Vang with Fresno Center for New Americans. I work there as a community outreach advocate. Besides that, I also work with the Building Healthy Community Coalitions here in Fresno. Our mission is actually health for all, regardless of your legal status. And as a Medi-Cal enroller and a certified Cover California enroller, I'm at the forefront of all this enrollment, and all the reports that have been reported to you, all the data is spot on. I just wanted to let you know residents have benefited from the Affordable Care Act, and they are calling our nonprofits worried about their coverage and how they will go forward with this. And so I want to urge you to urge your colleagues in the federal government to you vote no for the new proposal plan. And I wanted to let you know, the ACA provided opportunity for residents in America, not just in California, for affordable care. The key word being affordable, and so I just wanted to let you know about that, and to thank you so much for this opportunity. We see you as our champions for the ACA, and so we look forward to joining hands with you in the future. Thank you.
Thank you very much.
Good evening. My name is Miguel Villegas. I work with CRLA Foundation. I am here to speak on behalf of the farm workers and also the undocumented communities and also indigenous communities. And I think we all aware that up till now, many farm workers and indigenous communities don't have health coverage. They were able to receive help from MISP, but that was removed as well. So I just want to urge you to continue fighting hard. We are here with you, and I want to give you a message from our communities that they were so excited last year when we were telling them that the medical expansion was covering their kids, and now we're gonna have to go back and tell them that it's not gonna be effective anymore. So I think we should continue fighting, and I thank you all for supporting us today. Thank you.
Thank you.
Hello, my name is Amy Arland, and I am a critical care nurse here in the Central Valley, and I've been working here for over 16 years. Although Obamacare, I think, was a giant leap forward in providing care for the members of our communities, I do believe that Trump care is a certain death sentence, and that here in California, we have the opportunity in front of us right now, as Dr. Kratzer said, to provide every member of every county in all of California with a single-payer healthcare system. And let me just tell you that nurses are the #1 trusted profession in the United States. And as a member of the California Nurses Association, if we have 20,000 nurses that are telling you that this is a viable plan, we definitely think that you should trust us and consider that SB 562 is the right move forward. Thank you.
Good afternoon. Thank you so much for holding this hearing today. I am here. I work for CIVIC, known as Central Valley Immigrant Integration Collaborative. I got a little nervous. But I'm here because we work with hundreds of immigrants through all Central Valley. And just to condense a little bit of what I've been doing, we go and spread the word, not just on citizenship and DACA, but also to refer them to health access programs. And many of our partners are actually here today. But there are a few women who actually requested for me to, if I ever had a chance to speak for them. And I told them, you guys have a voice. You guys need to be part of it. But unfortunately, they're field workers, and if they don't show up to work, they don't provide for their home. But 2 of them, their children have leukemia and neurofibromatosis. And without Medi-Cal, they wouldn't be able to cover these expenses. Therefore, I plead, we keep fighting, and I thank you for it. And please be the voices of our immigrant communities and everyone who needs health access. Thank you for your time.
Thank you.
Thank you. Hi, my name is Christina Roop. I'm the Executive Director for the local affiliate of the National Alliance on Mental Illness. I just spent half a day with a group of law enforcement officers helping provide support and education for them to learn how to respond in the community to mental health crisis. If we reduce access to those services, it's not only going to impact the individuals who are living with a mental illness, their families, it will impact the communities. We already see that impact now. Stigma is a big barrier to reaching out. Many people who are affected by mental illness already experience feeling unworthy and undeserving. If they don't have appropriate access and resources for their own treatment, how can we expect them to step forward and get better? Let's do all that we can to make sure that those resources and accesses are available to our individuals who are suffering so that they can live a better quality of life. Thank you.
Very much. And last but certainly not least.
Thank you. Good afternoon. My name is Melissa Reyna, and in my employment, I work to enroll individuals into Medi-Cal and Covered California as a result of the ACA. However, I'm coming here just to ask for your help, again, to work with your colleagues to develop a better plan for California, but also every other American as well. The new proposed American Health Care Act, it's nothing more, honestly, than a name to make it sound inclusive for all individuals. Healthcare, how can it even say it provides healthcare? There is no means to provide any type of comprehensive healthcare in it. American, how can they target it to be every American, where now you're going to be forced to pick and choose who's going to be eligible for coverage or not based off of the different financial constraints that are set forth as a result of it. So again, just ask that you continue to work or continue to advocate to ensure that every Californian, every American, again, has coverage to what they currently have now. Preserve the coverage they have now. Don't allow them to have a negative outcome in life because they won't be able to access any type of specialty care or preventative services. Again, just to work that you preserve the coverage or develop a better mechanism. Thank you.
Thank you so much. That'll end our public comment. And I just want to say thank you to everyone. I'm going to give my colleagues, Mr. Santiago and Dr. Rambula, an opportunity just to close here. But I want to thank everybody for coming out today. I think this was an amazing event for an opportunity for us to hear from you, which is absolutely critical. So thank you once again for coming out. Thank you to the City of Fresno for letting us use your amazingly wonderful facility. We'll do everything we can to clean it up really quickly. And at this point, I'd like to pass this off for final comments from Mr. Santiago.
Bueno, muchas gracias a toda la gente que ha venido ahora aquí. Les agradecemos mucho que hayan venido y tomar mucho tiempo de su día para participar en lo que ha pasado ahora. Y les pedimos que sigan en la lucha y voy a demostrar unos diferentes tipos de cómo hacerlo. Pero primero sí quería compartir un poquito de la vida mía, porque también mi madre es una de esas señoras y mi padre que pediría cubierto médico si esto pasaría. And I was just saying that, this is a personal issue to me because my mom and my father would also be people who would lose that if the ACA were dismantled as it is today. And let's be very clear, and I've said this before, people could die from this. And this vote is a very serious vote. And it's an emotional issue, but I want to put it into brief context in terms of what we're really facing here. If this passes, the current Republican plan, we will be at a significant deficit in the state of California. We're not going to be talking immediately about what programs we develop. We're going to be talking about what we save, because they're going to give us a flat grant. Medicaid or Medi-Cal, as we know it today, will not exist, and people will fall off the rolls. So as emotional as it is, and as angry as people get, what we share in common is that we want to prevent those who are the worst ill to prevent them from potentially dying, and that's really the reality when it comes to healthcare coverage. So let's not be fooled about what we're really facing. We're going to face a devastating budget shortfall, and almost up to 5 million people, when this is done, will fall off the rolls. That is our reality. Not to mention transportation funding that we'll potentially lose, not to mention law enforcement money that we'll potentially lose. This is absolutely catastrophic. So everybody here has to understand that we share the same goals, but we've got to be patient with one another in this conversation, because we just can't make money tomorrow. That's a fact. And we'll share devastating losses in this state. Now, there are some things that we can do. And I'll challenge everybody here, right? You can walk precincts and inform the people about what's going on. You can make calls to your Congress members. You can send emails to your friends and Congress members to do the same. You can leaflet. You can put up posters. You can call your editorial boards. You can do op letters. You can ask your local councils to pass resolutions. You can blog about it. But you can show up to your Congress member's office. You can hold press conferences, call the press yourself. But at the end of the day, you guys all got to go vote for those who are eligible to vote and can vote. Because we're not going to change what is happening in the minds of some elected officials who think it's okay. And this is not the group of people, obviously. So let's be very, very clear. Even though you may be angry with us at times because the issues are so emotional, but really it is your congressional members who are going to make these decisions. So it's absolutely imperative that you register to vote, that you vote, and that you get everybody to vote so that something like this doesn't happen again. So I want to thank you, and particularly Mr. Wood and Mr. Rambler, who took the lead on this. Thank you.
As an ER doctor, sometimes I had to have what I deemed courageous conversations. Conversations that weren't easy to have, but needed to be had. Today's conversation is much the same. This is not the place that I thought we would be when I ran for office, and yet this is exactly the place that we are as our country. And it's going to take leadership and hearing from our community to ensure that we, the elected leaders, are getting it right. This is our time to have our voices be heard, and I wanted to thank everybody who came out. It meant something to me to do this in my backyard, to do this right here in the central San Joaquin Valley, and I just wanted to thank everybody for coming out and making today such a success.
And with that, we are adjourned. Thank you.